Recording in progress.
Hello.
Yes.
Is Shobit going to be starting it or should I start it?
You started, sir, because we are live.
Okay. Hi, friends. Good afternoon again. It gives us great pleasure to invite you for the 12th core series of PGs. And this time we've got a great academic feast for you. The moderators for the session are Professor Saravdeep Dutt of PGI and additional Professor Dr. Vishal Kumar, who's currently in AIMS Yogurt. Both of them are specialized spine surgeons, and you've got a great faculty from all over the country, which will be introduced to you as we go along by Professor Saravdeep. Prof. Saravdeep, would you kindly take over now, please?
Thank you, sir, for the kind introduction. I'd like to good afternoon, invite all the esteemed faculty for this 24th meeting. So we're going to have this is going to start from about 4:20 and this is going to carry on till about 6:50. And in this we are going to have some directed talks from everyone. We're going to start off by talk by Dr. Ram Chadha, ex-IOA president, and he's going to talk about why is spine more important to PGs. Then we have an interesting talk by Dr. Rupender from 32. He's going to talk about interpreting spinal scans. Later on, we're going to have a radiologist, Dr. Chirag Ahuja from the Department of Orthopaedics, Radiology in PGI, who's going to speak about how to read an MRI. This is basic stuff for PGI students. After that, we're going to have Dr. Rupender Chal from Gangaram in Delhi. He's going to give us a very nice examination talk, how levels of deficit, interpretation of bladder bowel issues, and basically how to approach a patient of a spine backache. After that, we can have about 5 to 10 minutes. That's about 5:15 to 5:25. Dr. Dr. Vishal and Dr. Rohit will be there, and there'll be interactive discussion and student questions or anything related to the WAB talks. The next session after that, around 5:25, you're going to have the degenerative spine. That's going to be by Dr. Rishi Khanna from Ganga and Coimbatore. He's going to talk about how to interpret and treat degenerative spine. After that, I'm a professor of orthopedics at PGI Chandigarh. I will be giving just a simple talk, how I would approach a patient of scoliosis. If someone comes to the clinic, what you should know about scoliosis, how to approach a patient, how to examine him, and basically come to a conclusion how to treat that patient. After my talk, Professor Dr. Bhaskar will be giving a talk of management acute spinal injury. What the resident should know, just like a patient who comes to emergency, how would you manage these patients of spinal trauma injuries? Then after that, there'll be an interactive discussion, which will be between Dr. Rupinder Chal and Dr. Rishi. They'll be taking interactive discussion, student questions on basically all these talks on anything required. And after that, the last talk, which will be application of indication of spinal braces. This will be led by Dr. Vishal, and discussion will be Dr. Rupinder, Dr. Rishi, and Dr. Bhaskar. And later on, to end the session about just close to 7 p.m., myself and Dr. Vishal will take over and just have a brief up and take home messages. So Vishal, please, could you please start by introducing every speaker, and I'll be just laying low and listening to what everyone's saying. Thank you.
Yeah. So now we'll be having a recorded talk of Dr. Ram Chadha, our IOA president, incoming IOA president, and he will be speaking on why is spine important for PGs. So, Dr. Sovik, can you start his talk?
Dinesh, start the video.
Good evening, viewers. Today I have the privilege of introducing an eminent spine surgeon from Mumbai, Dr. Ram Chadha, sir. Sir is a senior consultant orthopedic spine surgeon associated with Leelavati Hospital, Jaslok, and Global Hospitals, Mumbai. He is President-elect, Indian Orthopaedic Association, Federation Delegate, Asia Pacific Orthopaedic Association, Past President, Association of Spine Surgeons of India, Bombay Orthopaedic Society, and Bombay Spine Society. I welcome Dr. Ram sir for a talk for the postgraduate students, why spine knowledge is important for an orthopedic surgeon, for a budding who is in training orthopedic surgeon. So over to you, sir, and thank you for being a part of this core series.
Thank you very much, Shobit ji. Good evening, colleagues. At the outset, may I express my gratitude to Dr. Mandeep Singh Dhillon, Sarvdeep, and my dear friends from the Department of Orthopaedics, PGI, Chandigarh, and the Professor D.S. Grewal Memorial Orthopedic Society, which, along with Integrates Orthopedics, has come up with this comprehensive orthopedic residency education core series. Today, being series 12, I'm here to share my thoughts as to why spine, a subspecialty, is important for orthopedic PG postgraduate teaching and training. If you look at the internet, and I'm sure each one of you do, the 10 reasons to visit your PCP or primary care physician worldwide is for an annual health checkup, skin allergies or other allergies, back pain number 3, and joint pain number 4, which means we actually address probably the largest cross-section of people who visit for any form of medical care. The 10 commonest reasons to visit a doctor: skin disorders, joint pain, osteoarthritis, back problems. Interestingly, if you were to also check and ask for the top 10 doctors in the world, at number 1, you'll find Dr. William A. Abdu. He happens to be an orthopedic spine surgeon from the Dartmouth Institute, medical director there at the Hitchcock Medical Center. He is one of the best orthopedic surgeons and has contributed not just to patient care, but to research and academics. What I have learned over the last 3.5 decades is that orthopedic spine surgeons, and hence the spine subspecialty, can make unhappy patients less unhappy for some time. Hence, it's an integral part of our teaching that we concentrate and understand spine as a subspecialty and an important part of orthopedics. Each surgeon carries within himself a small cemetery where from time to time he grows to pray, a place of bitterness and regret where he must look for an explanation for his failures. Gentlemen and ladies, always be open to learn, unlearn, and relearn. It's time that we look back, look at the skeletons tumbling out of our cupboards before focusing on the future. I take you back 2 decades plus. Idiopathic adolescent scoliosis. I was extremely happy for having operated this young lady. Unfortunately, she had a post-operative neurological deficit. It was the patient who was now out of focus, the family, the caregivers, very unhappy. And I still go back, before the surgery, retrospectively looking back, in the month of January, where Janus means looking back, looking forward, as to those peering eyes which had so much of fear and grief when I suggested surgery. What is fear? Fear is false evidence appearing real. And when we are having fear, we either freeze, flight, or fight back. It's our duty as the treating doctors to allay the perceived fear and share the real fear. It's always to be an informed, shared decision. Unfortunately, our patients come with a lot of excess baggage, perils of the past and fear of the future. We need to look at them with pragmatism of the present. This profession of ours will always suffer because there's a huge dichotomy: diagnosis and treatment. Diagnosis is built on suspicion, doubt, skepticism, which we call investigations. And treatment, it's based on faith, belief, and trust. And we need to live up to the hope of our patients. Hence, in spine and in orthopedics, remember, healing is the purpose, treatment is only a process, and diagnosis is but a product. We unfortunately begin from below and go up, while we should always begin with the end in mind. Remember, there are worries and concerns that the patient and the family have. Can medicines help? Will bracing help? How safe is surgery? Is surgery the only option? Being orthopedic surgeons does not mean that we have to operate every patient. Any side effects of the surgery? What if she gets infection? Can she get paralyzed forever? Can the surgery fail? Could she need repeat or revision surgeries? Very important question you need to ask yourself. What would you do if she is your daughter or sister? Can you guarantee 100% success? Should we be concerned about radiation hazards? And in our country, how much would it cost? Dear friends, all our answers have to be tailor-made for that specific person in front of you. You may call him a case in the exams, but he is your teacher. He's the one who's holding your hand and telling you how to address the situation in future. Each patient is different. The answer has to be least objective, more subjective, and personal to that person. We have to listen and be silent, assimilating, absorbing everything. How does this work? Yes, you have to be charming, yet correct. You have to exercise excellent communication skills, open and frank communication. It's a creative art that builds each day. I am still learning, and so would you till the last day of your life. This is a lifelong pursuit. Always remember, all of us do not have equal talent, but we all have the same opportunity, the same time to develop our talents. We have to practice both advice and counseling. 2/3 of back ailments do not need pharmacology. They need just advice and counseling. Mental health consultations are important, essential, and very common. Depression and anxiety are a part and parcel of almost every back pain. Nothing in the world can bother you as much as your own mind, I tell you. In fact, others seem to be bothering you. It's not others, it's your own mind. There are 9 components to effective communication: listening to the patients, respecting their views, open communication about all treatment references, discussing management options, allowing them to ask as many questions, ensure that they've understood, be aware of their language, accept all cultural influences, and compensate whatever communication issues there may be. Remember, you are neither above them nor below them. You are besides them. Hand hold them. Uplift their state of mind. Practice not just verbal, but non-verbal skills. Have a shared understanding, open, attentive posture, eye-to-eye contact, active listening. Keep nodding. Let them tell their story. Ask open-ended questions if there's any additional concern. Remember, their mind, like yours, is a beautiful servant, but a dangerous master. Practice what Albert Mehrabian said in the 7-38-55% rule. 7% is verbal, the spoken word. 38% is vocal, how you say it. And 55% is your body language. This is an integral part, and we need to learn that at the postgraduate level. Always think before you talk. Think is an anagram. Is it true? Is it helpful? Is it inspiring? Is it necessary? And is it kind? Finally, don't just look, but see the patient. Don't just hear, but listen to the patient. Don't just touch, but feel the patient. Don't show pity. show compassion. Don't show sympathy to the patient, show empathy, put yourselves in their shoes. Truth and transparency build trust. Remember, the outcome is far more important than the income. Move from just bookish knowledge from wisdom gained from each patient after examination. Don't look at selfishness, but selflessness and altruism. What's best for that patient, his family, his society, and the world. Don't just use information which is bookish, but what you've got and gained from other patients. Reform and transform your practice. Don't just do your duty. Find your calling, your purpose, your passion. Look for those values. Don't just touch and contact the patient. Develop a connection, sanjog. Stop doing just kriya. Move to karma. It's then that we'll move from treatment to healing. And whenever I see any patient, I always say this silent prayer, the serenity prayer of Reinhold Niebuhr, which connects my heart to my head, to my hands. I say, God, grant me the serenity to accept the things I cannot change, courage to change the things that I can, and wisdom to know the difference. Why do we say this as orthopedic spine surgeons? We have to remember that as surgeons, we can only change, alter, modify the anatomy, the structure, and hope that that change in the structure improves the physiology, improves the function and the outcome. Remember, as always said, and will be repeated by my colleagues who have excellent presentations after me, that a good surgeon knows how to operate, but the best surgeon knows when not to operate. Thank you all for a very patient hearing.
Yeah, our virtual thanks to Dr. Ram Chadda for a unique, one of its kind of lecture. Now we move on to our next. Reading spinal radiology is very important for postgraduate trainees, and we will be having in our next lecture by Dr. Rohit Jindal. He is Professor GMCH Chandigarh and one of the strong pillars of spine surgery in North India. He will be speaking on interpreting spinal CTs. Professor Rohit, sir.
Good evening, everybody. I thank the organizers for giving me the opportunity to speak on this. I'm quite intrigued by Dr. Ram Chadda's words of 3 Ps: process, product, and the process, product, and the purpose. So we have a product that is CT, and if we follow the process, I think we should achieve our purpose. So to start, any spine CT should always be on CT viewer. There is no point looking at films, and CTs being multiplanar suit themselves perfectly to an axial structure such as spine. So my focus of this talk is to basically make the listeners understand the process of interpreting a spine CTs rather than giving too much values or too much figures to remember. So once you start reviewing a CT, always review the scout image on topogram, followed by the sagittal views, the coronal views, the axial views, and then any special views or 3D reconstructions that you might want to see the pathology or see for your preoperative planning. One thing is very clear, that one should be looking at a 2D structure and while trying to make a 3D image. So as you can see on these 3 colored dots, the coronal view moves from anterior to posterior while the sag views move from right to left. So in a mixed sagittal plane, as you can see, the blue dot, it is anterior, the yellow dot, it is in the middle, and the posterior dot, it is in the posterior. So one always needs to look at a scout view. So that's why it is very important to view on the CT viewer rather than view on the films. Before you start, you should know what the tools have. CT is a wonderful thing which gives you a lot of tools to improve your understanding of the pathology. It has windows, bone and soft. Bone window would give more of bony detail but would not give that much of soft tissue detail. But the soft tissue window give more of soft tissue detail, but the bone structure might be lost. So you need to see both as per your need. And then there is a spine window also, which you can see. And then these are household units. This tells about relative density of soft tissues. We are all aware of it. The things which are relevant to spine is that air is blackest of all, fat is black, and followed by bone, which is the densest of all. And any air in a spine CT is an indicator of instability, or maybe an indicator of instability in trauma and degenerative situations. As you can see, my cursor is pointing to a unstable Anderson's lesion anterior. The anterior part of it is which is being shown on this coronal view. And another photo is showing a facet instability. And sometimes, and trust me when I say this is not uncommon, although there have been only few case reports, you can find intravertebral air, which is due to air producing bacteria and particularly associated with pyelonephritis. So you should not be pointing it as just artifact. It can be due to air producing bacteria. And then bone is the densest, so you can see as my arrow is pointing towards the calcification of ligamentum flavum or a calcified disc or ossification of the posterior longitudinal ligaments. All these are important because when you are doing decompress, these are actually denser than bone, and doing decompressive surgery, you might struggle a bit. Very important. It's not only important to see the spine, but you can see the anterior structures where you can see a calcification of the vessels, and which is very important when you are contemplating a anterior approach. Another tool in CT scan is multiplanar formatting and 3D reconstruction. That is what gives the CT its weight and importance. The multiplanar formatting is process of converting data acquired in a plane to another plane, and the software tools can be used to format the data according to your wish. Just for one example, I've shown sacrum, where you can show the intersection of red and green lines. When you take orthogonal views, but these are not true views of sacrum, you see a view like this. But once you make it parallel to the orthogonal views of sacrum, you can actually see something like a proper outlet view on which you can use, make your measurements and see whether you can put a iliosacral screw comfortably or not. And this 3D is also very important because I particularly look when doing any revision or a congenital case, because you can put it prone and see actually how you would see the spine. As you can see, there is a large bony defect here. This is a case of L3 hemi. So you can actually see what is to be in front of you while operating. And one should know what is, the next point is one should know what is normal. So I would run over few slides to show what is normal. So we'll go from top to bottom. Sagittal view of cervical vertebra. You see the alignment. So you see the dense process. This is the anterior ring. This is posterior ring. All of this might be known to you, but it is good to recount this. Posterior spinous processes and lamina, and particularly in spine, you see lot of facet dislocations. So as you go parasach, you would see the respective right and left facets, and you can see intervertebral foramen. I just put an X-ray to make you aware that the difference in CT as well as the X-ray. So this is a mid sagittal level, and then you can see the soft tissues. As we teach in X-rays, at different points in the cervical column, you can see, and these are the normal values. You can follow the rule of 2 or whatever. Basically, more than 20 mm at the lower cervical levels, and 5 to 10, more than 10 mm at the upper cervical levels should cause you concern and warrant further investigations. And then the coronal views. the God has made spine symmetrical. So besides remembering too many values, the important point is to remember that everything should look symmetrical on a coronal view. So you can have an anterior where you can see odontoid, the lateral masses, and you can have a posterior view which will show the lateral masses and of the cervical vertebra. And these are the axial views where you, again, the same structures are to be seen, but axial views are good to see the canal and the axial anatomy as well as the depth. Mind you, because of, as I told you about the axis, never would an axis pass through the correct axial view. So you might see some gaps. So it is very important not to be misled that there is a defect here, and you have to find the correct axis for your view. These are various values which I don't want you to burden with. You can always look at it, which show you different measurements, logical measurements, which help you to reach a diagnosis of basilar invagination, any subtle trauma, or any instability. Now coming to the sagittal views of lumbar, as I told you earlier, you go from right to left, and parasag views, you will see the pedicles, you would see the foramen. In the mid-sagittal views, you will see the spinous processes, the disc, the vertebral bodies, and going further lateral, you would see the facets, the inferior articular process and the superior articular process. And on the coronal views, going from anterior to posterior, you would see the vertebral bodies. You can also make out some soft tissues, like here, you can easily make out psoas views. And as you go posterior, you will come across the facet joints, the superior and the inferior articular processes. And further posterior, you will see the lamina and the spinous processes. And this is just an axial view which has been labeled, which shows a vertebral body, which shows a pedicle, which shows vertebral canal and lamina of the vertebral arch. And this is an axial view. The previous was an axial view at the pedicle level. This is an axial view at the facet level, where you can easily see the sagittally oriented lumbar facets, the inferior one as well as the superior one, besides the spinous processes. And this is a soft tissue window in which you can make with clarity, make out with clarity the various muscles. And if there is a psoas abscess, you will see it in the psoas thing. Sometimes there is a post-operative psoas hematoma leading to unexplained pain. You can make it out, and then you can see the paraspinal muscles also. The endoscopy surgeons are very fond of showing these images to say that the paraspinal muscles have not been touched. So this is a good view to see that. And then you can make out ligamentum flavum also. Not as clearly as MRI, but you can have an idea about it. Now coming to thoracic spine, the axial view at the pedicle level, you would see that you can see aorta on the side, you can see ribs on the side with double attachment to the transverse process and the body, and you can see the lung fields. And here you will see that the facets are coronally oriented. So you must all take this in view while making a composite picture of the relevant pathology in your mind. Now coming to sag views, the mid-spinal view would show you vertebrae and bodies, while the parasag views, as in lumbar spine, would show you the foramens, the pedicles and the facet joints. This slide I have shown earlier, again to emphasize that while seeing coronal view, you have to have a spouting sag view, and while seeing an axial view also you have to have a scouting sag view so that you know where you are. Now once we have seen the normal CT scans, we should know how to interpret these CT scans. So mnemonics make it easy to remember. So ABCD, as in X-rays, you see for the alignment, you see for the bone, you see for canal, cartilage and disc. So one might say, how would we see cartilage and disc when CT is for bony detail? But there can be indicators of this pathology on CTs. So these four lines, well-known lines, anterior line passing the interior, touching the interior borders, the PLL line touching the posterior vertebral body, then the spinolaminar line, and then the spinous process line. So very easy to see that these should be in line, then the sag view is all right. And once you see that these are not on line, then you should see for parasagittal views to see, as here can be seen, there is an obvious facetal dislocation and a pedicle fracture also at C6-7 level. After A comes B. So CT is meant to see the bony detail. So as you can see, the bones which are destroyed, you can pick up the posterior fractures. Here you can see that C6 has been completely destroyed by caries spine. And all the views, it can be seen on sagittal coronal axial view. And you can see that again a case of caries spine in which L4 to S1 is lost. And then coronal also you can make it out that the vertebral body is lost. And then comes the most obvious advantage of CT over X-rays, that is to see the canal. When I say canal, I mean ring. So you can see the posterior structures as well. You can see the canal compromise as well. And you can see it both quite well on, not only on the axial view as one might expect, but also on the sagittal view. Here you can see the peripheral calcification so characteristic of a tubercular abscess. And then you can see abnormal calcifications in form of discs, in form of ossification of posterior longitudinal ligaments or OLFs or ossification of ligamentum views. Now I would quickly run through certain illustrative examples to make it more clear how do CT scans help in processing the data that we have, or how we can process the data better for our understanding. So this is one illustrative case of hangman's fracture. On an X-ray, you can make out that C2 is a bit anteriorly subluxed and in kyphosed position with relative to C3. But once we see the CT, so a lot of more pathology is seen. One can see a right C2 pedicle fracture. One can see an obvious subluxation of C2, C3. One can see a C2 body fracture, which is so common in these fractures, and a contralateral pedicle fracture, which involves the foramen also. This not only tells about the pathology, but also tells us the type of fixation which might be safely possible in this case. And when you go axially, you can see that spinal canal is being compromised by a bony fragment. You can make out the pedicle fracture. And coronal view would also show, in these cases, one can have a CT angio also, which will also show you the vertebral artery in relation to the bony structures. The coronal view is important because you are exposing posteriorly, so you want to see where the vertebral artery is, which is most at risk while doing these cases. So another illustrative example of odontoid fracture, and the same fracture with a screw in place. Just the multiplanar capability of CT gives you easy access to see what you have done, and you can see that the C1, C2 lateral masses are in place, so there is no subluxation, and this is a good case for interior fixation. And PLC, the PLC now is a big thing. Every classification points to evaluating PLC. And MRI, I find CT also a very good means to examine interspinous widening, as you can see at the injured level as compared to the other levels. And you can see in contrast that a type A injury would have the interspinous distance same. And the same fracture, you can best pick up the posterior fractures, like in this case of chance fracture, where you can see the facet fractures or the posterior body fractures on a CT scan. And this is a type C injury where you can see the facet dislocation. Sometimes this is also called a naked facet sign because the facet is not here and you can see that the facet has dislocated. But does CT pick all spine injuries? So CT is very good, particularly in the area that we practice in North India. There is a lot of central cord syndromes. the CT might look absolutely normal, but once you get a CT MRI spine, you can see lot of intramedullary changes. So CT is very good modality, but it can miss injuries which are not associated with bony injuries. One should always be mindful of that. Another case in which the CT would appear normal. In retrospect, you might see a slight widening, but the MRI would show you that this is a hyperintensity signal. So this might be a quite unstable fracture, whereas the CT would show that it's a stable injury. So one should be mindful of the shortcomings of the modality also. CT scan is very helpful in picking up foraminal stenosis. There have been some classifications. As you can see, the double whammy of a disc, calcified disc and the superior articular process can lead to a grade 3 or a grade 2 stenosis, and you need to decompress the exiting route. That is, for L5-S1, we are accustomed to seeing the S1 route only, but you have to see the L5 route also for a good outcome. A similar case, again the multiplanar, I put this X-ray. So you can exactly see on the axial view where we are and the right or the left side and where the pathology is. Again, there is a joint facet osteophyte and a calcified disc. And then you can see, mind you, these small osteophytes are often the major cause of compression in stenosis cases. A typical trefoil canal can be seen. The facet is subluxed as well as it is hypertrophied, leading on to compression of the neural elements. So lytic slip, you can see indirect as well as direct the stenosis, and you can see the pars defect. CT in deformity is particularly useful in picking a diastem, bony diastem, seeing the type and the dimension of the pedicle, the Wattenweg classification, which you can look up, whether it is a cortical window, is a cancellous window, it is amenable to expansion, or you need to think of alternative fixation, and very useful in picking up congenital deformities like a hemivertebra or a bony defect. CT in infection, MRI obviously in spine is the major thing, but CT in infection can pick up bony destruction, a bony squastra, and then the posterior elements also, which sometimes the bony destruction cannot be picked up that well by the MRI, and you might have to think of a posterior approach in addition to an anterior approach if you are planning it in first. And another very important important contribution of CT is a directed biopsy, because CT you can see axial views, you can go with a thin needle, you can go with a thick needle. With fluoroscopy you can only get a bone, but a directed biopsy you can aspirate and send the material for culture sensitivity, which is becoming more and more important nowadays with more of pyogenic infections as well as MDR TB. So CT retains its importance in infections as well. And there is a case of odontoid, like a C1, C2 caries. You can see the involvement of the facet joint as well as the destruction of the odontoid on CT, which might not be that easily picked on MRIs. And CT in tumor is very, very important. MRI might make the diagnosis, but you need CT to quantify the bone lysis and directed biopsy as explained earlier. Why it is important to see? So now a lot of literature is coming on prophylactic fixation of METS lesions. So you see this SINS score, the three main things, the radiographic spinal alignment, the vertebral body collapse, posterolateral involvement, and the bone lesions can only be commented upon CT. So CT is a very important modality for characterizing a particular metastatic lesion and the need or otherwise of fixation. And postoperatively also CT scan is very important. You need to see the implant fusion, as you can see a C lateral mass, the sacral screws or the translaminar screws. You can see for the restoration of disc height and the foraminal height, and you can look for fusion. So CT scan has great importance in post-operative evaluation. And mind you, nowadays, lot of robotics and navigation is coming, which is basically a intra-op CT. So each of us needs to be very well versed with the CT findings in different planes, so that one can make a intra-op decision based on CT. So in the end, I would say that CT is an essential part of diagnostic preoperative planning and postoperative evaluation. One should always see on CT viewer, I cannot emphasize it enough, a systematic approach to interpretation of CTs would lead you to the better diagnostic and understanding as well as preoperative understanding. Please make use of all the software tools. With the progressing technology, you are getting new and newer tools which greatly help you to increase your information preoperatively about the case, and be aware of limitations of CT also. And you might feel that the thank you slide features beetles. Why so? Because it is believed that the commercial development of CTs initially in 70s was funded by money from the Beatles, the sale of the Beatles record, because the same company was making the CT which was selling the Beatles record. Thank you. Thank you so much. So I'll hand over to Vishal for further.
Thank you. Thank you so much, Professor Rohit, for such an illustrious and elucidative, practice-based, approach-based talk, which I think it goes a long way in the exit exams of the postgraduate trainees as well as their career. So now again, I will like to invite one of the India's top-notch brains, neuroradiologist, Dr. Chirag. We will be speaking on how to read spine MRI, because it's also an integral part of postgraduate exit exams. So Dr. Chirag, it's all over to you now.
Thank you so much, Dr. Vishal, for the kind introduction. So I'll not take much time. So thank you, Dr. Savdeep and Dr. Vishal. So what we'll be doing in the next 15 minutes or so is try to understand what is an MRI, how is it can be useful in spinal imaging, and how to interpret this basically. So I'll begin by what are the principles of MRI? Unlike CT scan, which is based on X-rays, that means radiation, MRI is completely free of radiation. So it is a non-ionic, non-radiation-free modality to image the entire spine. In addition to the osseous anatomy, which is very well seen with X-rays and CT, MRI helps us in looking at the ligamentous structures, the nature of the disc, as well as the intraspinal canal. So the acquisition techniques, unlike CT, most of the time CT is acquired in a volumetric format. However, in MRI, classically, we acquire images in a 2D format. So the images can either be in thickness of, let's say, 2 millimeter or 3 millimeter. There are techniques currently which are also available, in which you can actually do a 3D volumetric acquisition, but the signal of that particular sequence is not very good. So to say that the marrow signal does not really help us in interpreting the signal changes of the soft tissues happening there. It might be good for anatomy, but then anatomy, as we have seen, Dr. Jindal has beautifully shown that CT actually in osseous anatomy is very, very good. So what we basically want to look at now is the soft tissue details of the spine. So as I said, the acquisition techniques are basically of two types. It can be a turbo spin echo or a gradient. So these are the two methods by which imaging in MRI is done in any part of the body, and it is true for spine as well. So classically, I think in most of you as postgraduates would still see films. We always advise, if you have the chance and the ability to have a look at the MRI scans on a DICOM viewer. So that is every film is in DICOM format. That is the best. But we've seen more than 80 to 90% of the centers still are giving films, and most of the orthopedicians still have to interpret based on their film, the understanding on the film. So on film, you will see typically spine images in either a sagittal format, axial format, and sometimes you also take a coronal format. So you have to understand and you have to know the anatomy before you really start interpreting your scans. So the typical sequences that are acquired are T1 sequence, T2 weighted sequence. I'll speak to you in detail about how the image interpretation on these sequences is like. Flare sequence and a post-contrast or a post-gadolinium T1 sequence. So these are the basic two pillars, I would say, in terms of sequences that MRI is based on. And you have to understand and know, obviously anatomy you all know, but you have to understand which image are you looking at before you actually decide on what pathology you might be looking at. So this is what a T2 image will look like, and this is what a T1 image will look like. So on T2 image, the cerebrospinal fluid, so all the fluid structures inside the body, be it the CSF, be it the urine, the pelvic system, be it the bile in the biliary duct or the gallbladder, essentially will look bright, and this is referred to as hyper-intense signal on MRI. In CT, we refer this as hyperdensity in terms of density, as has been shown previously, the attenuation values. But in MRI, you talk about intensity. So this is hyper-intense CSF. That means this is a T2 weighted image. So the first step in analyzing a pathology is to identify what image you are looking at. So CSF looks bright, hyper-intense on T2, and it looks hypo-intense or black on T1 weighted imaging. So this is the first sine qua non of identifying an MRI image. So we'll directly start interpreting the spine MRI. So in addition to the image, so I would say if you have a DICOM viewer, try to acquire the entire MRI imaging data set in the DICOM format, put it to your viewer, and it will be very, very interesting and easy to look at the images either from right to left or left to right, and you'll be able to have reference lines, which image you are seeing in the sagittal plane, and the same reference you can actually extrapolate into your axial planes. However, as I said, most of you will have to look about the images in the film still. So in films, what you will see is, in addition to the patient characteristics and the institute characteristics, or the annotation that you see typically on the left upper corner and the right upper corner, which is not highlighted here, you will see something in the left lower corner as well as the right lower corner. So what it means, I will basically tell you. Now, T is the thickness. So this is the 3 millimeter thickness of this image, of this slice. So what it means is a 3 millimeter thick section at this location is actually collapsed into a single imaging plane into this 2D format. So what you are seeing in this image is basically a contracted or a compacted volume of 3 millimeters, and all the data in that thickness is actually made available on this single image. So logically, if you think, if you have a more thick image, that means let's say you have a 10 millimeter image, and then the entire volume in that 10 millimeter image will be compacted into a single image, and the resolution of that image will not be very good. On the contrary, if you have a 1 millimeter section, the resolution will be very good, but then the image interpretation will be again limited by significant artifacts which happen during the acquisition of 1 millimeter section. So somehow over a period of time and with experience, we have come to know that between 2.5 and 5 millimeter thickness, the image interpretation is very good, and that is the ideal thickness that one should acquire the spines at. Now the next is L. So this is basically the position, slice position or the level. So this level is at 25. Now I'll show you the corresponding second image. So this is the second image. Thickness still remains 3, but now the level or the next slice position is at 28.5. So now you will wonder that if the thickness is 3 millimeter, the next position should be from 25 to 28, which is not the case. So look at this, 25 and 28, it is 28.5. That means there is an inherent problem with MR acquisition, and the MR acquisition plane has to move by 0.5 millimeter, and any pathology which is less than 0.5 millimeter can potentially be missed by the typical MRI acquisitions that we perform. That doesn't mean that you will always miss these pathologies. Why? Because you can always look at images which are also given in other planes, like in axial or coronal section. So it is always good, and in fact, I would advise you all to look at multiplanar images before you finally reach at a diagnosis on MRI. So 3 millimeter section image, but 3.5 millimeter bar, that means you have missed 0.5 millimeter section here. Now on the right, so WL means window level and WW means window lift. So as in photography, we refer to the settings of the image in terms of brightness and resolution. So this is almost similar in the imaging interpretation, where you can actually change the window levels and window widths to actually change the brightness and the contrast of a particular image, so as to get the maximum resolution of that image. So if you look at the right lower corners, there is something called TR and TE. So TR is nothing but an inherent physical component of image acquisition. TR means the relaxation time and TE means the echo time. So a short TE and TR means that you are looking at the T1 image, while a long TR and TE means that you are looking at it T2 image. So sometimes in a plane, in one image, you may not be able to see the fluids. Like in this case, you're not sure whether this is a T2 image or a T1 image, because we are not in the middle of the spinal canal. You actually cannot see the CSF. Although if you try to look around the posterior fossa, you can see a thin line of T2 hyperintensity. That means that is CSF within the posterior fossa. This is likely to be T2, but just to be sure, you just have to look at the values. If you see TR level which is very high in thousands, that means that image is T2, while the low TR and TE, that means the image is T1. So apart from that, so you have either to move from right to left or left to right when you are looking at the images. Most of the times, it will be there in the scanogram provided on the upper left corner of any imaging film. However, you can actually, it is actually a convention that more than 95 to 99% of the centers give you images from right to left. So you can safely assume in most of the images that the first sagittal image that you are seeing is possibly of the right aspect, and subsequently it moves towards the left. Now, as we come, so now coming on to the anatomy of the cervico-dorsal MRI. So in the right lateral aspect, this is the right side because we've just started. What you see is the marrow of the vertebrae here, but you are not seeing the vertebral body as such, because it hasn't, this image plane hasn't reached to the mid-sagittal aspect. So this is the parasagittal component, and here you are able to identify the intervertebral foramen. So this is very important to identify, as in most of the cases, I would say in a major chunk of the cases of MRI, we'll be suspecting discal pathologies. And so this secondary to discal pathology, you'll come across nerve compression, which is of utmost surgical importance. So if you see hyperintensity around a central hypointensity, that indicates that there's a big wide space in that intervertebral foramen, and there's a good amount of fat here, and the nerve traversing through the fat is actually in a very, very good status, completely decompressed, and there is no compression whatsoever. Now, apart from so coming back to what the other structures look like on T1 and T2, so the fat in the subcutaneous plane, as well as the fat adipose tissue in the spinal canal, in the epidural space, as well as the intervertebral foramen, will also appear bright or hyperintense in T2 as well as T1 weighted imaging. So this is fat which is actually encircling the traversing nerve roots, and which shows that the nerve roots are fine in this case. And this is how you will see like a typical keyhole appearance of the lateral traversing neural foramen. So once you come to the mid-sagittal location, you are able to identify the vertebral bodies, the intervertebral discs, and so the T2 hyperintensity in the center of the intervertebral disc is due to high water content inside the nucleus pulposus in the central part of the disc, while the rest of the disc, the peripheral part of the disc, is composed of annulus fibrosus, which has a lot of fibrous tissue, and this gives a signal of hypointensity on T2 weighted images. So as the disc degenerates and desiccates, the central T2 hyperintensity is often lost, and this is referred to as disc desiccation, which is the early signs of disc degeneration. So apart from the alignment of the spine, which you can actually appreciate very well on CT, the discal anatomy and the information is very well demonstrated on MRI. So you will be able to identify like in X-ray and CT, we say the height of the disc. in fact, height of the disc space. However, here you are able to see the disc in entirety. So you refer this to as disc height rather than disc space height, because you are actually able to see the disc here, while in the X-ray and CT, you are not able to see the disc. So you can see the signal intensity of the disc, the height of the disc, as well as its anterior and posterior herniation. Like in this case, there is a posterior bulge. However, the epidural spinal space is still very well preserved. There is no significant compression on the spinal cord. And at the same time, in the same breath, in the same go, you have to also look at the spinal cord and have to communicate the findings. So there is no altered signal changes seen in the spinal cord, which typically will show you as hyper intense or subtle whiteness that will start coming on this spinal cord, which indicates that there is compressive effects and compressive myelopathy and secondary vasogenic edema, which is developing due to compression of the spinal cord by either the disc or sometimes, in many cases, the fracture fragments following trauma. So this is the mid-sagittal location. You can actually see the slices of the various vertebrae, vertebral bodies anteriorly, and the spinous processes. What is also important is, in addition to the anatomy of the spine, the spinal vertebrae, you also have to look at the marrow signal. So what actually is very, very difficult to appreciate on CT and X-ray is beautifully picked up on the MRI. So a normal anatomical marrow signal on T2 weighted imaging is slightly hyperintense as compared to the surrounding muscles. Like this is the muscles of the tongue, and these are the muscle, the ligaments, and so you have to compare the signal with the muscles in the surrounding zones. So the marrow signal is slightly bright on T2 weighted imaging, and this is the normal marrow signal. This is the normal marrow signal. However, at this point, the vertebral body marrow shows a different signal, which is T2 hypointense. So this has to raise a suspicion in your mind that this vertebral marrow is not normal, and you have to try to further evaluate it. Apart from this, the vertebral heights have to be seen, and obviously at this point, there is a significant reduction in the anterior height of this vertebral body. And usually in the radiological parlance, we say that at the cervicodorsal and the dorsolumbar junction, the anterior wedging of more than 25% should be considered significant in elderly patients. Till about 25% compression, we usually take it as normal, provided the marrow signal should be normal. Like in this case, it is definitely abnormal, and the anterior wedging is up to the tune of 40 to maybe even 50%. So as we go towards the left now, we again see the neural phenomena, the intervertebral disc, the annulus component, and as well as the lateral arch elements. Now, in addition to that, you should always look at the alignment of the posterior arch elements. The articular facets is important. So the inferior articular facet should be flush and in close apposition with the superior articular facet, and you should see a hyperintense signal ideally at the facet joint. This means that the joint is good, the articular cartilage and the some amount of fluid here is normal, and there is no significant arthropathic changes still developing in the facet joint. This is especially useful to look at in the dorsolumbar junction, because that is the place where the facetal arthropathy develops as a degenerative change initially. So I'm going to the lumbar spine. So in addition to that, I would always recommend you to number your vertebral bodies beginning right from C1, because many times at the lumbosacral junction, you would be able to find in a small subset of population transitional vertebrae. So counting the vertebra, if you have an entire scan of the spine, it is always good to start from these C1 and C2 vertebrae. So always go cranio to caudal direction. If you just have a lumbar scan, obviously you have no choice. You have to assume the last well-formed vertebral body, which is aligned in the mid-sagittal plane, to be L5. So as I said, coming on to the lumbosacral spine, again, I'm going from right to left. You have to identify whether this is an L2, a T2 image or a T1 image. So obviously, fat hair and going to the mid-sagittal section, CSF hair makes it a T2 image. Now, so try to look at the heights of vertebral bodies, look at the marrow signal. This marrow signal in these two vertebral bodies is significantly different as compared to this vertebral body. So is this marrow signal, and there is a very well-defined lesion in the marrow involving this vertebral body, and the caudal body is almost completely collapsed. So obviously you have to think of some marrow infiltrative pathology in this particular patient. And so if you see carefully, in addition to the vertebral body, you are able to see some distinct soft tissue in the prevertebral space. So always try to look at the adjoining structures in addition to the obvious, the spinal canal and the spinal vertebral anatomy. Also, look at the surrounding structures. Here, this soft tissue should make you think that you are looking at a marrow infiltrative pathology, which has a significant amount of soft tissue. And in elderly patients with multifocal lesion with soft tissue, marrow signal infiltrative processes are most likely to be metastatic in origin. So again, coming to the midline, obviously prevertebral, not much of a problem. What your intention is to look at the soft tissue in the spinal canal. Now the CSF space in the cranial direction in the ventral and dorsal aspect of the cord is maintained. The CSF is maintained. However, as you go caudally, you are actually missing the CSF signal entirely. So obviously either the cord has expanded or there is some soft tissue which is originating from the surrounding vertebral bodies, vertebral marrow, which is causing compression of the spinal cord. The likely chance of the lateral is more because there is a marrow infiltrative pathology at this level. So obviously, as you come down, the CSF again starts to appear because at the corresponding level, vertebrae appears and the marrow appears fine. And obviously, there are no lesions here. So as you go more lateral, again, try to appreciate, as I was telling you about the facet joint, there are some initial changes which has started happening. There is some thickening, T2 hypointensity. So arthropathic changes have also started appearing in the facet joints at this level. So coming on to the other image, again, T1 sagittal, the CSF is now hypointense and you are able to distinctly see the altered marrow signal involving these vertebral bodies, which are actually better picked up on a non-contrast T1 weighted image. Why? Because on a T1 weighted image, the marrow looks significantly bright as compared to the intervertebral discs as well as the CSF. So we usually say that the pathologies usually are better picked up on T2 and you should start looking at the T2 image first. However, in marrow infiltrative pathologies, the pathologies are eye-catching and evident much earlier on a T1 than actually on a T2 because of the inherent bright nature of marrow on T1 than T2. So again, the same thing, soft tissue, intraspinal extension, spinal cord compression, prevertebral component, altered marrow signal. However, the vertebral height is maintained here. However, there is complete compression at this level. So again, now here comes the importance of contrast administration. Now, so before I show you the coronal images, I'll directly go to the contrast, and this is how you will appreciate contrast T1 images. You should note that contrast gadolinium, that means gadolinium-based contrast agents are administered on a T1 image, or in fact, after administration, we acquire a T1 image because the gadolinium is a T1 contrast and not a T2 contrast. So it is always T1 contrast that you have to look at. And in fact, the T1 contrast shows you the altered marrow signal very, very much clearer than you actually saw it on T1 and T2 weighted imaging. So always do a contrast imaging if you are suspecting infiltrative pathologies and it actually or infective pathologies. So when discal pathologies of degenerative nature, contrast is usually not recommended unless it's a post-operative disc and you are trying to look at any associated inflammation or infection. So now I'll go back to another image, which usually we take in the coronal plane, and you have to start to see the coronal plane either from the anterior to posterior format or a posterior to anterior format. Choose your format or choose the image format which has been provided in the film or the imaging database. So we are starting in this coronal image. So this is a flare image. What you see, flare in the sense a T2 fat saturated image in which the fat in the subcutaneous plane has been suppressed. So this is all fat which is suppressed. This better brings out all the edema in whatever planes which is bounded by fat. So in here, the soft tissue is very well seen. If you appreciate, the soft tissue is in the lumbar plane, which you were able to see on the right side in the paraspinal location, is actually extending much more laterally and almost involving the entire musculature and the intervertebral, in the rib spaces, in the intercostal spaces, unlike on the left side where you are able to appreciate the suppressed marrow signal of the normal rib. So this is so we are starting from posterior to anterior, and this is the large soft tissue which was seen associated with the marrow infiltrative pathology. In addition to the spine, it is always valuable to look at the surrounding structures. Like in this case, you are able to see the kidneys on either side, right side and left side. Again, as I said, you are always visualizing the person from the front, as if you are seeing from the front, and in the axial plane as you are imaging the person from the foot end. So the right is always, your left hand is always the patient's right. So this is right kidney, left kidney, hyperintense, normal, but there's a lesion. Superior to that, there's the liver, and there are multiple lesions there. So it is indeed a metastatic pathology, which in addition to the spinal involvement is also involving the liver and the kidneys in this particular patient. Again, soft tissue is seen in the lateral lumbar area as well as the paraspinal location. Multiple liver lesions. Always look at the surrounding region. Try to look at the muscles also. So this is the psoas, and this is especially useful in our scenario in the Indian subcontinent, where you see a lot of tubercular infections, and invariably you'll see a lot of psoas collections as well. So this is what a normal psoas would look like. Straight lateral margins, no inherently altered signal areas, while in collections you'll be able to identify peripherally enhancing central T1 hypointense collections, which need to be either aspirated or drained depending on the volume. And depending on that, you need to either, again, put a pigtail or maybe a small collection actually resolve with a good ATT treatment. So as you come anterior, you are able to appreciate the water content in the nucleus pulposus in the disc. The marrow signal is suppressed because this is a T2 fat saturated image. And this is in the background of a suppressed marrow signal, the lesions are brought out very well. So again, I've already showed you this contrast image, the other imaging plane. So I would always say, instead of looking at each of these images, T1, T2, and post-contrast in isolation, try to put them all three in one single image if you can, and try to compare here. This is a T2 image, T1 image, and a post-contrast image. So all these images have their inherent nature, duty of demonstrating a particular pathology. Now, this is what an axial image would look like. So this is the spinal canal, cauda equina nerve roots. This is the intervertebral space from which the nerve root is capacious, and the nerve root is going out fine. There is no compression whatsoever. This is the psoas muscle on the right side, and the left side seen beautifully. And obviously, this is all the retroperitoneal fat and the perineal fat, which is seen all around the right side and the left side of the kidney. Anteriorly on the left side, you'll see the aorta, and on the right side, you'll see the IVC. So the structures, vascular structures on MRI will appear hypo-intense because of the high flow, and they will not give a signal. If you see hyperintensity in the aorta or the IVC, you should suspect either slowing of flow, atherosclerosis, or thrombosis in these vascular structures. Again, contrast axial beautifully depicts the contrast enhancing lesion in the vertebral body. Now, as I said, if you have a DICOM imaging viewer, it is it becomes very easy to actually identify which level you're talking about. So this is a discal level at this level, and you are able to see the cross-section axial view of the disc, beautifully showing the central nucleus pulposus and the circumferential peripheral annulus fibrosus. So the imaging plane, the imaging scanogram lines will really help you in identifying the location of these vertebral disc and the body. Similarly, this is how a marrow will look like vis-a-vis, again, going back to this is what a disc would look like on axial plane, and this is what a marrow signal would appear on axial scan in this T2 weighted image. Now, again, disc on T1 weighted image, as I said, the water looks hypointense. So this is the nature of the disc, which is hypointense on the axial plane. On T1 weighted image, it is almost impossible to differentiate nucleus pulposus from annulus fibrosus. Again, axial T1 distinctly showing the marrow replacing pathology in this at this particular level. And this is the large soft tissue, which is actually infiltrating the surrounding muscles. The rib is also destroyed. There is an altered signal in the rib as well. So I'll briefly end by showing you some of the pathologies. Obviously, MRI will not show you the distinct pathologies, but then with an understanding of the anatomy, you will be able to identify much more that you will be able to see on CT. CT again, C2 body fracture. You are able to beautifully see the fracture line on the CT in the sagittal plane, coronal plane, the dislocation also, as well as the axial plane. However, here MRI is required to really know the status of the spinal cord, which is beautifully seen on MRI T2 weighted imaging, which actually shows the compression of the spinal cord. So in this hangman's fracture, again, obviously CT will tell you everything. However, the nature of the compression on the cord is useful, and the ligamentous injury, discal injuries, the injuries which are not picked up on CT, the epidural hematomas are actually better seen on MRI, and this is really useful. Although I would agree with your argument that many a times these patients are not fit for MRI, but then to give appropriate management, I think MRI is to be done in the clinical suitable conditions. Hyperflexion, typical hyperflexion distraction injury, the ALL is preserved. There's a hematoma in the subligamentous zone. There is an anterior and anterolisthesis of the C5 over C6 and posterior ligamentous injury and hematoma as well. Hyperextension injury, you will see there is dislocation of the facet joint at this level. Now, spinal cord injuries are not picked up typically on CT or MRI, which we refer to as skivoras. And MRI is really useful when there's a significant radiological clinical mismatch and you are suspecting spinal cord injury, where the CT and X-ray more or less appears normal. Again, a sequelae of a whiplash injury, while the musculoskeletal component was essentially normal. Again, hyperextension injury, there's a significant problem in the anterior pillar with a prevertebral hematoma. Wedge fracture typically seen, you all know. Burst fracture, and the two pillars are involved, and there is posterior convexity of the involved vertebrae and actually causing compromise of the spinal canal and spinal cord compression. Again, another burst fracture, fracture dislocation. And this is the intervertebral discal injury, which is beautifully seen. CT will just show you anterolisthesis, while actual injury of the intervertebral disc, which is seen to compromise and compress the spinal canal, is better seen with MRI. So I'll not go into the details because I'm short of time. Just will show you, I think, some more examples. So sometimes you'll be able to appreciate the destruction of the vertebral body on CT. However, this soft tissue, which is actually compromising the canal, may not be seen on CT, and MRI is really helpful to show the extent of the soft tissue collection, which actually needs to be drained in this particular case. Many a times you'll see these flow voids. This is what we call flow voids. And as I told you, the artery and vein, the flowing blood is black. So these are flow voids indicative of vascular structures. You do a DSA, and this is a spinal arteriovenous malformation, which is causing myelopathy. So this is a cord infarct. Patient presented to us with sudden onset paraplegia, and there is some hyperintensity on T2 weighted image here in the ventral aspect of the cord, which on T2 is kind of a wedge shape, but actually restricted to the ventral component. You do specific sequences also, like in this case, we did a diffusion weighted imaging, and this shows restriction or hyperintensity, indicating that it's not simple myelopathy, but an infarct which has involved the ventral part of the cord. So I'll not conclude by giving you any message. However, this is how you interpret MRI. And I would, in fact, urge all the residents to go through the films, try to read whatever you can, and this will really help you in actually developing an interest for MRI. Thank you so much.
Thank you, Dr. Chirag, for making reading of MRI such a lucid and pleasant experience for all of us. Now it's really our privilege, rather not mine, to invite and listen and learn from Dr. Rupinder Chahal. Sir is also famously known as Spine of Association of Spine Surgeons of India, a senior consultant, and also the spine of Sir Gangaram Hospital. All over to you, sir. Rupinder sir, you are not audible, sir. Unmute your mic, please.
Am I audible?
Yes, sir. Yes, sir.
Yeah. Thank you, Professor Dylan, Vishal, and Saravdeep, and the whole organizing team for giving me an opportunity. Please do warn me. I think we are already overshooting the time. It's a vast topic. And let me begin by a small case. This is a 46-year-old male who presented to our department with the right lower limb radicular pain for 3 months and anterior thigh pain for just few days. And this was the time when I was in the ICS Bhubaneswar, and our fellows had seen this patient and examined him. So he had a similar pain in the right leg 4 months back, for which the pain management team gave him a transforaminal root block. It relieved his pain for 1 month, but reoccurred again, but now has come with an previous thigh pain also. So on examination, his SLR was positive. That is what they examined and sent it to me. And as a routine, we get these dynamic films. This is very, very important as far as the teaching program in a degenerative spine. Most of your investigations, MR, CT, and normal X-rays are all static, and most of the patients' complaints are either in dynamic nature when they are doing something. So always try to get a dynamic view, so you'll pick up certain instability which may guide you to a better treatment in such cases. So this was the MR the patient already had 1 month back, and this was not though very clear, but did show some extra foraminal disc at L3-4. And so I asked them to get a screening of the this is what it was. And I asked them to get a screening MR to see if there's any new lesion had come up, because this MR, he had become pain-free after this. And so now this is this MR in the screening one. Dr. Chirag's already spoken about how to read an MR. This is the lock key sign where you see the nerve root surrounded by fat. And if you look at the right foramen, it's all obliterated by the disc. So he was getting this pain. So they said what to do. I said, give them a block. I am not here. So he was given a block. And the patient is actually a brother of one of our OT technicians. So there are 3-4 brothers working in the OT technicians. And every day they're after me that they used to call me to operate him. He was in terrible pain. These foraminal or extraforaminal discs are quite painful. And he had a complete relief of thigh and leg pain. But after 2 days again, he said he can't walk. He has no thigh pain now. And his now pain is more pain he's having is that pain which he had below the knee. So I had come back to Delhi then, and I did look at his MR again, the sagittal films. And now it was typically an L4 vein. So we start trying to look at what was happening. So if you look at, he again now had a L45HIZ on the right. So to just reiterate, this is actually over the root, and these are very, very painful lesions in young people. These are active discs. These are actually from where the nucleus, the chemicals, it's like putting a swab of a chemical right over the disc, and they cause a very bad neuritis. So he was getting this pain, and again, all his attendants were after me to operate him. I said, I am not having a great, he's having one pain better than the another. So I'm not very keen to operate him immediately. And so we gave him now an L4-5, right, transforaminal, extraforaminal root block, and his pain completely disappeared. These leaks, I'm telling you, they seal with time. And there's high chance that they seal. They can even burst and make a bigger protrusion, but most of the time it settles, and it's now 4 months, 3 months, is absolutely fine. So the take-home message from here is the correct localization of pain is key to successful treatment of any lumbar, spinal, or root pain. Non-dermatomal pattern distribution, multiple pain generators can be present, making diagnosis very, very difficult. So a sinovertebral nerve from one level can go and supply up at a different level. So it's very, very difficult to even make out on a clinical examination at times. So a careful clinico-radiological assessment can ensure effective pain relief. So if you look at this Venn diagram where you have the symptoms, the findings, and the image. So you don't operate the patient just on the symptoms when there is nothing on the image. Similarly, you may have findings, but they don't match with your images. So it is important that before you put a knife or a needle on a patient, you should be in this middle part. So everything should be in your favor. This is a degenerative spine. Even when you are 100% sure, the results are just 70%. So very, very important that you are, and A spine surgeon must play around with these blocks. They are very good. They give you the patient the confidence in you. They give the confidence to you to do a surgery if later required. They are therapeutic, they are diagnostic, and they aid a lot. So your blocks, you should give it to you or yourself, not the pain management guys. So we will look at in this topic, determining the levels of lesion is a cornerstone in diagnosing a spinal pathology. And the neurological function is well evaluated, best evaluated in a systematic examination organized by dermatomes. So each level, sensory, motor, and reflexes should be tested. So there are different motor tracts which go down and up, which let us know what is happening. It's not important to know all of them. For as far as we as a spine surgeons are concerned, the four important tracts, the corticospinal, the posterior column, the anterior spinothalamic, and the lateral spinothalamic are important and which have to be tested. There are 28 key dermatomes from C2 to S4 and 5. At each, three aspects are tested. That's the light touch, vibration, and the pinprick. And they are compared to a normal, that is the patient's cheek, that is used as a normal frame for reference. So the grade 0 is absent, 1 is altered or hyperesthesia, and 2 is normal, and 3 and the NT is not testable when there is some issues with the skin. Similarly, you have to assign key points at every level. It's important is we normally see the lesions at C45, L45, so we test those and we leave it. Let me assure you that unless until you practice all of them, by merely reading them before the exam will not help you. In any lesion, even if from history, you know, it is just a lumbar lesion and it may be an L45 level, your examination should start from the cervical. So every time you do it, you will be so sure that then only you will remember this. Similarly, assigning the level to a region is very important. You may know it is that the T4 will be at the nipple, T10 will be the umbilicus, and the D12 will be at the inguinal region. But between that, it is important that you learn those also. Similarly, the motor examination, you have to test the 10 key myotomes, that is C5 to T1 and L2 to S1. The test muscle utilizing the standard spine position and stabilization of the individual muscle being tested. Improper positioning and stabilization can lead to substitution by other muscles and will not accurately reflect the muscle's function being graded. So if you are testing a flexion of the elbow, if it goes into a pronation, then the brachioradialis plays a role in it. So if the patient exhibits more than 50% of the normal range, then the muscle can be graded through its available range with the scale 0 to 5. But if the range of movement is limited to less than 50% of normal, then it should not be tested. Similarly, you assign the different dermatomes to the myotomes to the different movements. The C5 would be, you have to test the elbow flexors, C7 the wrist extensors, C7 the elbow extensors. So similarly, this is important that merely testing one or two known myotomes is not, will let you memorize these. So you have to go through the whole list. Deep anal pressure. This rectal examination, most of the time people avoid it, and this is a major issue where you miss everything. This is important that you do a deep anal pressure and voluntary anal contraction examination, and that gives you a great idea of the prognosis and the extent of the disease. Reflex examination. The reflex examination is important for several reasons because reflex changes may be the earliest and the most subtle indication of a disturbance in a neurological function. The testing of the reflex is most objective part of the neurological examination. Reflexes are under voluntary control to a lesser extent than most parts of the neurological examination, and the reflex anomalies are difficult to simulate. So you have to grade them from 0 to 4, and unless until you keep doing it, you will now, it's very difficult at times to know what is normal and what is brisk and what is hyporeflexia. So you have to elicit the basic reflexes, that's the biceps, triceps, brachioradialis, quadriceps, and the archalis. This is how you test the C5 level, the myotome, the reflexes at the C6, So you can, I'll not go through this for the sake of time. And the C7, the T1, and the abdominal reflexes. So this is abdominal, you divide it into 4 quadrants and then you test them each quadrant. So the Beaver's test is when you test, when the abdominal musculature above C7 is innervated by T10 to T7 to T10, and the musculature below the umbilicus is from T10 to T11. So when patient is asked to perform a sit-up and the umbilical moves up, means the lesion is above T10. If it moves down, means the lesion is below T10. Similarly, the cremasteric reflex and the testing of the knee extension and the hip abduction and testing of the knee jerks, the patellar tendon reflex. Similarly, the testing the S1 and the ankle reflex. So it is important that you determine an accurate motor and a sensory level. The sensory level is the most caudal intact dermatome for all sensation. The intact dermatome level located immediately above the first dermatomal level with an impaired or an absent light touch or pinprick sensation is designated as a sensory level. So that has to be a completely normal level. Since the right hand side may differ, so you have to see it for both sides. So the motor level is determined by examining the key functions within each of the 10 dermatomes, myotomes, and is defined by the lowest key muscle function that has grade of at least 3. So it must have a useful power, provided the key muscle function represented by a segment above that level which you are saying is graded as grade 5. So this can also be different on both sides. So if you are vertebral lesion and a spinal level. So at C1 to C7, you have to add 1, T1 to T6, you have to add 2, and T7, T9, you have to add 3. At T10 vertebral level, the spinal cord nerve level is L1, L2, and T11 is L3, 4, T12 is L5, S1, and at L1, all sacral and coccygeal segments are. So bladder bowel symptoms is an important thing. It is, we really know that the bowel has an important intrinsic innervation which is independent of the spinal cord, but whereas it has a lot of extrinsic innervation also, both the somatic, the sympathetic, and the parasympathetic, and how they behave. It's a little difficult topic and involves a lot of coordination between these. So important is that it can be broadly divided into 2 headings. It's the upper motor neuron bowel syndrome and the lower motor neuron bowel syndrome. So the injury above the conus medullaris that causes a hyperreflexic bowel characterized by increased colonic transit time, anal tone, with disrupted voluntary external anal sphincter control, and the nerve connection between the spinal cord and colon remains intact. So the sphincter remains tight. So there's a retention of stool, there is a preserved reflex coordination and stool propulsion. Hence, UN bowel syndrome is associated with constipation and fecal retention, at least in part due to ES activity. Whereas in a lower motor neuron bowel syndrome, injuries at the conus or at the cauda, you have an areflexic bowel characterized by loss of spinal cord mediated peristalsis and a slow stool propulsion with an atonic external sphincter. Typically, it is associated with constipation and a significant risk of incontinence due to flaccid paralysis of ES. So you don't give suppositories in such patients, and it has a reduced motor control of the levator and eye. So the main implication of disruption of motor sensory and autonomic pathway post spinal cord injury can be the inability to feel when the bowel is full, voluntary control muscles to defecate, voluntary contract muscles to prevent defecating. So you can have 3 patterns. That's the pattern A, B, and C. So pattern A is the injury above the T7. It has a lot of issues involved, where the pattern B is a injury cord level below T7 with preserved sacral reflexes, and pattern C is a T7 injury with absent sacral reflexes. Similarly, the urinary tract innervation The main coordination center is the pontine maturation center. The violation control of maturation is controlled by the medial frontal lobes and the corpus callosum. In a suprapontine lesion, maturation occurs but is involuntary. The bladder's parasympathetic afferent nerve supply, which governs the contraction of the bladder, originates from the sacral cord at S2 to S4 and travels to the bladder via the pelvic nerves. The sympathetic afferent nerve, which increases the bladder storage, originates at T11-12 and travels to the bladder and urethra via the hypogastric nerve. The somatic afferent originates from the sacral segment at S1 to 4 and travels through the pudendal nerve and innervates the external urethral sphincter. So, a neurogenic bladder, the most helpful method is to consider bladder dysfunction as falling into one of the two categories. It's either a failure to storage or there is a failure to empty. These two categories are further subdivided based on whether the failure is due to problem with the detrusor or due to the bladder outlet. The example of failure to store would be a detrusor hyperreflexia or uninhibited bladder contraction or an areflexic bladder outlet. In contrast, failure to empty may be due to a areflexic bladder or a sphincter that is unable to relax. So any of these problems can occur at a different stage of acute and chronic periods of the spinal cord injury. So you can have an upper motor neuron syndrome or automatic bladder. The bladder dysfunction in the majority of the spinal cord injuries, that is the level above, can be categorized as an upper motor neuron dysfunction. Patients can be expected to have an involuntarily reflexive empty with filling of the bladder. In comparison, many incomplete patients will have a detrusor disinhibition results in urge incontinence. These injuries communicate between the pontine maturation center and the sacral maturation center is disrupted. This can lead to an impaired coordination of detrusor contraction with accompanying events such as relaxation of bladder neck, internal sphincter, and the external sphincter. The term used to describe this is a detrusor sphincter dysnergy. Whereas in the lower motor neuron syndrome, that is the autonomic bladder, the spinal cord injuries that present with LMN bladder dysfunction include conus medullaris and cordacoin injuries. These injuries interrupt the local reflex arc, which consists of efferents from the detrusor and sacral maturation center S2 to S4, and the efferent inputs to the detrusor. The end result is a detrusor areflexia, that's a hypocontractibility. Other clinical findings that accompany detrusor areflexia include sterile anesthesia, reduced sphincter tone, loss of voluntary maturation control, and absence of a bulbocavernous reflex. There is no ability to initiate voiding, no voiding reflex, and no sensation of bladder fullness. So if you really look into the pectoral thing, so you can have a suprasacral lesion or a sacral lesion. So normally there is a bladder, when it is full, it sends the sensation to the S1, S2 the sacral thing, from where the contraction occur and the bladder is empty. So if this red line that the brain control, the maturation center control is not there, it's always an inhibitory control. Then the person would be peeing every 10-15 minutes. Whenever there would be a urine in the bladder, it would contract and the sphincter would relax and there would be. So this inhibitory reflex that stops the bladder from emptying. So once this inhibitory or the suprasacral lesion is there, inhibitory is withdrawn. So the bladder at times will be full, and then the contractions will let you voluntarily empty it. So in a spinal shock, where there is an injury and there's a shock, the whole cord, upper and the lower function has not come up. There is no upper control. So there is no control over the bladder. So the bladder will keep filling and contracting and emptying. So this contraction will now it will become a very hypertrophic detrusor, which will become like a band thing. It will lose its elasticity. So the very high pressure builds up in such bladders, where compared to a normal bladder on the right side. So under normal bladder, when the pressure builds up, the detrusor muscle relaxes and the bladder capacity increases. Whereas in the suprasacral lesion, the bladder doesn't increase, the pressure becomes very high. So now this pressure is either there is a leakage of urine or the pressure is transmitted proximally through the hydroureter or hydronephrosis, damaging the kidneys. So this at times, there is a DSD, that is the detrusor synergetic dysfunction occurs, and there is no voluntary or there is no overflow or of the urine. So there is a outlet problem also. This leads to an autonomic reflex, which is very dangerous for the patient. Whereas in the sacral lesion, the sacrum sensation is not, the S1, S2, S3, 4 are not working now. There is no sensation control, there is no contraction. So this only, so you have a weak bladder and a weak sphincter. So there is an increase in pressure, but the sphincter is also weak and there is an overflow incontinence. But these patients, if they cough, they sneeze, then they wet this. So this is an socially an issue with these such patients. So any stress on them, they will leak. So the symptoms of neurogenic bladder, if you really look into it, in a normal, the bladder fills at low pressure, a good control contraction to empty the urine, and the sphincter is tightened during filling and relaxes during empty. Whereas in a patient with suprasacral spinal cord injury, it's an overactivity injury. So bladder spasms are there, there's a leakage, there's a high pressure, it causes hydronephrosis, the sphincters are don't open, so they retain urine. Whereas in the sacral spinal cord injury, it's an underactive thing. You have a flaccid bladder, it retains the urine, and there's a leak with coughing, etc. Thank you very much and wish you all a very festive season.
Thank you. Thank you so much, sir, for an enthralling and so clinic-based approach and deliberation. Now, it's my privilege to introduce my respected senior, Dr. Rishi, who is for us a surgeon to precision and a teacher to perfection. Presently a senior consultant at Ganga Hospital, Coimbatore, a team which hasn't left any award, be it national or international, in spine surgery to be won. So all over to you, Rishi, sir, please. Rishi, sir, you are not audible. Please unmute yourself.
Yeah.
You're audible, sir.
Right. Can you see my screen? Hello? Hello?
Yes, we can see you, sir.
Yeah, wonderful, right. So thanks to the entire PJ team for having invited me. And straight away, I will go into the topic. This is quite an extensive topic like the previous speakers have spoken about. It is about the degenerated spine and how to interpret it and how to treat it. So it's too big a topic to actually write a 2-volume textbook. So my goal in this presentation, particularly this presentation has been curated for postgraduate students who will be appearing for exams. So I'll be giving a bird's eye view of what we mean by spinal degeneration or a disc degeneration, and what it exactly leads to in the patient's vertebral column, and how do they clinically present. And when the patient presents to the spinal clinic with a certain constellation of signs and symptoms and MRI images, how are we going to interpret the diagnosis and how are we going to treat the patient? So a brief introduction to the anatomy. So whenever we talk about disc, we don't...
Sorry to interrupt you, the screen is not visible. Can you share it? Share the screen, please. The PPT.
Screen is not shared.
Yeah.
I had already shared my screen. Let me do it again.
Okay. Yeah, it's starting. Yeah, we can see now.
Okay, okay.
Yeah.
So the learning objectives of this presentation is to give a bird's eye view of what we mean by disc degeneration, the specific diseases and disorders, and how are we going to interpret in both through clinical manner as well as evaluating the patient's radiological pictures. So when we talk about a disc, we don't talk in terms of the disc alone. We talk about in terms of a motion segment. So vertebra. Two vertebrae which are adjacent to each other are connected by the intervertebral disc in front and by the two facet joints posteriorly. So this group of two vertebrae and intervening disc and the two facet joints at the behind are called as a motion segment. So we don't call a disc as an L4 disc, we call it as an L4-5 disc because the disc which is connecting the L4 and the L5 vertebra together. And if we take a cross section of an intervertebral disc, it has a central gel, what we call as the nucleus pulposus, and which is contained by the peripheral annulus fibrosus. So as the name goes by, the nucleus is fully made up of a gel-like structure, hence it is called as a pulposus. Whereas the surrounding annulus fibrosus is made up of more of a fibrous tissue, which provides the strength to the disc. So this combination helps the disc to serve as a shock absorber, as well as provides the stability to the spinal segment, the motion segment, whenever the patient bends and turns towards the side. And this the shock absorbing capacity of the intervertebral disc is given by its huge water content. So what happens to the disc as time passes by? So normally when a child is born and the child grows till 20 years of age, this is what we look in the MRI. So there is a peripheral annulus which is dark in color, and the central disc is full of the nucleus pulposus is full of water, and the disc serves its function very much. But in the third to fourth decade of life, normally for everybody, just like the hair starts graying, slowly the nucleus pulposus is the one which starts to degenerate first. So here by degeneration, what we mean is slowly the disc loses its water retaining capacity. So when the nucleus pulposus loses its water retaining capacity, we can see it in the MRI, it's becoming less white, it becomes more gray in color. So as the shock absorbing capacity is lost, so the disc now becomes stiffer, and now the stress is now borne by the annulus fibrosus. So whenever the patient bends and turns, more and more stress is taken by the annulus fibrosus. What happens next? Next in the fifth and sixth decade, the disc becomes completely worn out. Both the annulus as well as the nucleus pulposus have completely lost their ability to bear the stress of the spine, and they have become completely black. So this is the usual sequence of a disc degeneration that happens over a period of time. Not necessarily it will happen in all patients and it will happen in all the lumbar discs. Certain people are more prone for early degeneration. Some people will be prone for degeneration at one particular level, and some will be prone for degeneration at multiple levels also. So this pattern of disc degeneration was first described by Kirkcaldy-Willis. He described it in the 1980s. So what happens during the initial stages of dysfunction? So there is a stage 1 between 20 to 40 years of age when the nucleus pulposus starts losing its water content. All the stress I told is borne by the annulus fibrosus. So this is a stage when the annulus fibrosus starts developing small tears, which are called as the annular tears of the annulus fibrosus. So in this stage, these patients are more prone for a condition called disc prolapse. So the degenerated nucleus pulposus can suddenly prolapse out through the tears in the annulus and come out and cause nerve root compression. So this first stage is called the stage of dysfunction. And the disease which can happen in this stage is the disc prolapse. The second stage, when the patient passes to the next level, so now the disc has become more and more stiffer, and the annulus fibrosus is also has taken a lot of stress and it has become lax. Now the stress is transferred to the posterior facet joints. So now the facet joints have to bear the stress, whatever is happening in the motion segment at that particular level. So as the facet joints take up the stress, they become lax. So the facet joint moves in front, and this stage is called the stage of destabilization. So this is the stage the patient can develop a spondylolisthesis, what we call as a degenerative spondylolisthesis. Next comes the third stage where the disc, both the annulus fibrosus, the nucleus, everything have become completely worn out. And over a period of time, the spondylolisthesis is also stabilized. So how the facet joint stabilize is by hypertrophy. The facet joints hypertrophy as well as the ligamentum flavum hypertrophies. So now the spine is stable at that particular level. But in the process of stabilization, there is a lot of overgrowth of bones as well as the ligaments. And this is the stage the patient can develop a lumbar canal stenosis. So in stage 1, the patient can develop a disc herniation. In stage 2, the patient develops a degenerative spondylolisthesis. And in the stage 3, it can result in lumbar canal stenosis. So in summary, whatever we discussed now, so lumbar discs lose water starting from 20 to 30 years of age. This is what we call as a normal degeneration. But it could be abnormal in certain group of patients where it could be rapidly accelerating, and it could also be multi-level disc degeneration. And certain risk factors like genetic predisposition and certain work like drivers and smoking, all these things have been found to accelerate disc degeneration, making some group of patients symptomatic. So when we do an MRI, disc degeneration may be asymptomatic in many people, whereas in some group of people, it can become symptomatic. And how it becomes symptomatic is what we are going to see in the next few slides. So this is how a patient presents to the spine clinic, a 4 group of patients with the different types of spinal problem. All the 4 patients present with varying degrees of back pain or radicular symptoms. But as you can see, all the 4 MRIs are different from each other. So the first patient, basically the MRI is completely normal. You can see that all the intervertebral discs are fine. The vertebral bodies are fine. The spinal canal is fine. But still these patients are having back pain. So this condition, we call it as the myofascial pain, right? Or the fibromyalgia, where we don't see structural abnormalities in the spine, but the patient is having a lot of back pain. The second patient has more of radicular symptoms and less back pain, and he is suffering from disc prolapse. So this is an young patient who is in the stage 1 of Kirkcaldy-Willis disc degeneration. The nucleus pulposus is worn out and has completely come out through the annulus fibrosus. So third patient, he is having lumbar canal stenosis. As we can see, there is a degenerated disc, and there is a hypertrophy of the ligamentum flavum. There is complete occlusion of the spinal canal. There is a mild grade 1 degenerative spondylolisthesis. So he is in the stage 3 of Kirkcaldy-Willis degeneration. So the spine has stabilized now, but there is a lot of spinal canal occlusion. The fourth patient is in stage 2 of Kirkcaldy-Willis degeneration. So this is the unstable stage where there is a spondylolisthesis as well as spinal canal stenosis. So how are we going to identify these patients and plan the treatment is through identifying their pain patterns and pain generators. So basically, when the patient presents to the spine clinic, the first question you should ask the patient is whether your pain is in the low back region or it's a radicular pain or a combination. So if it is in the axial region, so if it is the pain is in the predominantly in the lower back region, think in terms of a pain arising from the disc, the facet joint or the vertebral bone. Whereas if it is a radicular shooting pain, think in terms of a nerve root compression. So this axial back pain is a wide diagnosis, wide symptom. So we need to put these patients in different boxes so that we'll be able to identify whether we are dealing with a simple disease or a complicated disease. So on one end of the spectrum, we have the simple myofascial pains or functional pains, what we call as a functional pain. So these are benign, non-specific, symptom-limiting back pain episodes where the MRI is completely normal and the patient doesn't have any radicular or neurological symptoms. Whereas at a complete other end of the spectrum, you have patients who have pathological conditions like infections or tumor, where the pain is very acute, severe, and associated with neurological problems. And this is quite easy and easy to diagnose and treat. Whereas in the middle, there is a lot of patients who fall into that group where they present with axial back pain to our spine clinic, where the pain could be arising from one of these spinal structures. Either it could be the intervertebral disc or the facet joints or the end plate. So how are we going to identify and treat these patients? So for this, we need to put them in back pain boxes. So this back pain box concept is very particular in our hospital. So moment the patient comes into our hospital and starts presenting his symptomatology, we ask these questions. How do you feel when you get up in the morning? And does the pain increase by your activity and decrease by rest? So this particular kind of pain where the patient is completely fine after a period of rest and pain-free in the morning, and the pain increases after a period of activity, you have to think in terms of a mechanical back pain, which is very typical of disc degeneration. The disc is degenerated, but it has not gone to the stage of a disc herniation. The second group of pain is called as the instability back pain, or the pain is severe in the early morning. The patient gets up with severe back pain and stiffness, and after a period of walking around, the pain comes down. He also has an instability catch. So he bends forward and does a work, and when he has to get up, there is a catch in the lower back region. So this is typical of a spinal instability as seen in spondylolisthesis. You should also take into consideration there are certain patients who have the inflammatory back pain. Again, it is severe in the morning, but it takes a long time to ease out. So these patients could be suffering from conditions like ankylosing spondylitis. So we'll see one type of pain, one after the other. So like I told, the first pain, the mechanical back pain, which is arising from a degenerated disc. So this, you can see it is a degenerated disc at L4, 5, L5S1 level. There is no big herniation. And these are the patients who present with axial low back pain, which is typically mechanical in nature. So why and how does this pain arise? So normally the majority of the disc is an aneural structure. It doesn't have any nerve supply. It should not feel any pain. Why in some patients disc degeneration causes pain? Because as the disc degenerates, there is a lot of stretching of the peripheral annulus. But the peripheral annulus is a innervated structure. So when the peripheral annulus gets stretched, they start developing back pain, typically activity-related back pain. Sometimes when the disc degeneration is quite severe, so if there is a severe disc degeneration, what we call as a Firman's grade 5 degeneration, the end plate also starts eroding. So when the end plate starts eroding, then there is the time the basivertebral nerves which supply the end plate through the vertebral body, they may also get incited, and the patient can develop back pain. So this is how a patient with disc degeneration develops back pain. So this is a very simplified model of how a discogenic pain arises. So as the disc degeneration starts, there are some internal disc disruptions. So this is called as an IDD, where the stress in the annulus causes small tears in the annulus fibrosis, and the patient develops back pain. Sometimes these annular tears can coalesce together and form a bigger tear. So this is called as a classical annular tear, seen as an hyperintense signal in MRI. And when these annular tears become bigger, that is the stage the patient develops a disc herniation. So how does the patient present? It will be like a deep aching axial discomfort, increases with mechanical stress. And this word is very important, centralization phenomenon, where the pain is present in the low back region and buttock region, but doesn't cross beyond the knee joint. So this is very typical where there is no nerve compression. So the second pain is the one which is arising from the facet joint. So the facet joint is a well innervated structure. So any problem within the facet joint, there will be a lot of pain for the patient. So which stage does it occur? So it occurs during the second stage of disc degeneration. So as I told earlier, once the disc becomes fully dehydrated, the annulus also is completely worn out. Now the stress of the motion segment is transferred to the facet joint. So as you can see, the second disc in this picture, the lower one, the disc is completely worn out, and now the facet joint is becoming inflamed and painful. So how does the patient present? So typically these people are around 50 years, unilateral pain, where even though the facet artery is bilateral, most of these patients present with unilateral. The pain is in the lumbosacral and paraspinal region. It is typically confined to the posterior thigh. It doesn't go beyond the knee joint. And these patients, they find relief with recumbency and increases with extension. And how do you diagnose it? So if you do an MRI, you can see a lot of fluid within the facet joint. So if this amount of more than 3 millimeter fluid is present, then it indicates there is a lot of facetal arthropathy. So there is some group of patients where the facetal arthritis, as it worsens, the patient can develop a spondylolisthesis. The bone starts subluxing forward. And this is the time they start from a mechanical pain to an instability type of pain. So this is a typical example. You can see there is a facetal arthropathy. And in the radiograph, in the flexion extension view, now the bone has also started subluxing forward at the L4, L5 level. So this patients now will have an instability type back pain. So the third group of patients who have vertebral end plate lesions. Now the disc problem has extended into the end plate. So these modic changes have been getting a lot of attention recently. And more studies have shown that these modic changes have to be taken seriously. So as we can see in the MRI in the L4, L5 level, the disc is degenerated, but there are a lot of changes, signal changes which are present at the L4 and L5 vertebral body. And these end plate changes are called as the modic changes. There are 3 types in it based on what we see in the T1 and T2 MRI images. They occur as part of the spinal degeneration, and these are really painful conditions. So basically, as I told earlier, normal cartilaginous end plates are not innervated, but after the disc degenerates, the end plate along with the facet joints, they take up the stress, they start cracking, and then soon the edema develops in the end plates. So how do these patients present? Again, it will be axial pain, again centralization phenomenon, pain confined to the loin and thighs. But the pain is very severe, especially after a period of rest. So the moment the patient gets up in the morning, a lot of pain will be there. And some patients can develop instability-like symptoms. Again, MRI is a concluding thing to diagnose these patients. So just to summarize this, any patient with a degenerated disc disease and he presents with axial back pain, how are you going to pick them up? So the first group, myofascial pain or fibromyalgia, it's a mechanical type of pain aggravated by activities. Severity is mild and chronic. Diagnosis is purely clinical and treatment is by physiotherapy. Patients who have disc degeneration, they have again mechanical pain. The pain severity is more intense. MRI helps in diagnosing the condition, and most of these patients do well with conservative treatment. The third group, they are now reaching advanced stages of degeneration. They develop facetal arthropathy. So initially the pain characteristic is mechanical, and once they develop instability, they have instability type of back pain. Diagnosis is by MRI, and the stress X-rays are very useful in these patients. So whenever they have instability type back pain, always get a flexion extension radiograph to diagnose this problem. And they are very well treated by spinal injections, and sometimes surgery is indicated. Modic end plate changes, again the pain is mechanical but severe pain. The pain is quite severe. Diagnosis is through by MRI, and if conservative treatment fails, these patients may need surgery. So coming to the more easier type of pain to diagnose and treat, that is the radicular pain. So here the pain radiates down the leg all the way up to the foot. So this is called as a sciatica type of pain in common parlance. Most common reason why patients present with this problem is a disc herniation causing nerve root compression. But you should also understand that sometimes stenosis can also present with unilateral radiculopathy. So clinical presentation, usually it is an acute onset radiating pain again, after lifting weight or bending down or a sudden cough, the patient develops the pain. Peripheralization, so typically the pain goes into the posterior or the lateral aspect of the cough. The pain goes along a particular dermatome, and the classical diagnostic clinical test is a straight leg raise test, which has good specificity and sensitivity. And if the patient is having a crossed SLR positive, then it has more specificity. And based on the pattern of the pain, where the pain starts and where the pain goes, and where do they have the numbness, we'll be able to make a clinical judgment about which nerve root is affected. But ultimately, the final conclusion would be made by the confirmation is made by the MRI scan. So this patient is having an L5S1 disc prolapse presenting along the S1 nerve root. So there are a lot of other pain generators in the spine. Once you are able to rule out all the 4 or 5 conditions which we discussed earlier, they form the bulk of the patients who present with the degenerative spinal problems. Rare situations, you should also think about these conditions. So in conclusion, spinal degeneration is a complex disease. Still, a lot of research is going on. There are certain things which are very clear and easy to make out when the patient presents to you, but there are a lot of things where you need a lot of experience and a repetitive clinical examination to come to a conclusion. So disc degeneration, facetal arthropathy, and plate changes, they all present with axial pain. First question, ask the patient to point the area of pain and go through the history in detail to find out whether it is a mechanical or a instability type of pain, or if it is a radicular pain, so that you can make a rough clinical diagnosis. And then get an investigation like an MRI. And a lot of insight can be made if you correlate the clinical presentation with the clinical examination along with the MRI, rather than going through based on MRI imaging alone, and then you can treat accordingly. Thank you so much, PGA team, for giving this wonderful invitation, meeting all of you.
Thank you so much, Rishi sir, for making this seemingly tough topic for postgraduate trainees so intriguing and lucid to learn and imbibe. Next, I take pride in requesting my own teacher and mentor, Professor Saravdeep, who will be taking on a scoliosis examination. He is a spine surgeon, so clear in approach and management that I am yet to find one. Thank you, sir. Please, stage is all yours. Sir, please unmute yourself, sir. Saravdeep, sir, please unmute yourself. Sir, Saravdeep, sir, you are not audible, sir.
Sir, you are not audible.
Yeah. Now, yeah. No, not audible. Sure.
Hello. Maybe some.
Vishal, you can hear?
Yeah. Now we can hear, sir.
Now we can hear you.
Sorry, something. My fault. Yeah, I don't know what's
Yes,
happening.
Sir. Yes, sir. Please.
You can see now.
Yeah, sir.
Okay, sorry. It was showing that I'm not able to change the slides because of I don't know why. Okay, now. Sorry to keep you waiting. This simple talk how I would approach a patient with scoliosis, and I think so. Scoliosis is something which we are increasingly seeing a lot in our practice, and knowing what a patient with scoliosis will come and what age group patients will come to you in clinics is most important. So once you have that in mind, what kind of patient you want to see, the better you're going to understand how to treat a patient with scoliosis. Just for a simple view, what is scoliosis? Basically, it's a abnormal lateral curvature of spine in which deformity in the coronal plane up to 10 degrees is normal. So normally, you might see patients who come to OPD and they might come and some might come and tell you that, we have some deformity or we fell down or something happened. But if you do like a normal survey of children in the schools, you may not be able to pick up scoliosis. So a lot of patients who come with idiopathic scoliosis, especially adolescent age group, you don't actually see them till the patient parents or someone complains. So if you see that what happens to sagittal plane is that there are a lot of compensating mechanisms, but yes, up to 30-35 degrees thoracic is normally seen, and lumbar lordosis is 50 to 60 degrees. So if you get any rotation here, that's when it causes the posterior prominence. So if you see about 2 to 3% of children below 16 years can get it, so that's quite common. 0.1% have a greater degree than 40 degrees by the time they present to us in clinics. Girls are more affected than boys, and those with the curve with more than 30 degrees are generally girls. So you see this, when you see a girl, young girl, who's about 12, 13 years old, who's just come from school with her parents, and they come to complain, the first thing which comes to your mind is that patient may be having scoliosis. And because these girls tend to have a growth spurts before boys, that is about 10 or 12, 13, right before the menarche, is when they notice this deformity. So you have to understand anatomy-wise, if all the bony elements are altered, the vertebrae are wedge-shaped, the rib vertebral angle is altered, the pedicles rotated, it's just a three-dimensional deformity. So you have to understand that anatomy-wise, you can go look into it more. I'm not going to teach about that, but that you have to understand when you're looking at from outside, when you're looking at the child walk in, you have to understand there's a lot of dynamics happening inside the spine. So when the patient comes to you, so what happens is it's very important to understand age. So there are two subsets of patients which you'll obviously see in your practice. One is a young child, and he could be a syndromic child, or it could be a child who's walking with a little gait disturbances, and he's brought with his parents, and he comes to you maybe 4 years old, or maybe even 2 or 3 years old. So what they complain of is most important. And then another subset of children who complain of backache, and these are young kids, maybe 12 or 13-year-old girls, or maybe 10-year-old girls, who basically complain that they have a pain while studying, or they're not able to play for long, or they have a difficulty in basically just carrying their school bags. So these are two subsets of patients. What the subset says that one is congenital, that the patient may be born with it. Other is to understand the patient is become adolescent and is having a growth spurt and causing this idiopathic scoliosis. So number two is evidence of maturation. You have to understand that patient is adult or young. You have to understand how old it is, patient is menarche or not. Number three, most important point is presence of back pain. Lot of the children who come adolescent idiopathic scoliosis, which come at 12, 13 years old, these are the children, especially the girls who complained of pain while lying down or pain while playing and stuff like that. And the other thing which you have to see is neurological symptoms. Like Dr. Upendra Chal has given a very good talk. You have to see the child walking, how the patient is walking. Is it tilting toward one side? Is the shoulder heavy? Is the child crooked or bent forward? Does he have difficulty high stepping gait? Do you think the patient maybe have DDH or maybe having cerebral palsy? The way the patient walks in is very, very important. And then basically seeing the child as a wholesome. You see the mother and father. Mother may be like 5 foot 2 inches, and the father may be 5 foot 10 inches. And then you have a child who walks in who's only 4 feet. So you have to keep things in mind, and you see a larger perspective when you see this. And also you ask about the family history, if anyone else had in the family, or how many siblings the patient has. What you see the child when it comes to clinics is you have to see the shoulders, and the shoulders are uneven. One or both shoulders may be sticking out. The head is not centered rightly above the pelvis, so there's kind of a scoliosis or rotation happening. One or both hips are raised unevenly high. Rib cages are different heights. Waist is uneven. The appearance or texture of the skin overlaying the spine has to be seen, and the entire body leans to one side. So this is a case in which you will see that everyone is, these children have come to you, they're slightly bent forward, little crooked, and they may be walking a little funnily. So what do you see physically? What you see is you have to take a physical examination, see this child, and you see that take out the height measurement, do a good gait check. see the foot shapes, see the skin inspection. You have to ask the children, especially the girls who stand with the parents, and ask the mother to make the child comfortable that I'm just going to see the back. I'm not going to do anything else. So you make them remove their clothes, give them a gown if possible, and then you can inspect the skin. You have to assess the pubertal development. You have to use the Tanner staging, which I'll just talk about. You have to see breast development, how the child is, does he have any hair on the body or not. These are signs show that the puberty is set in. You have to, the neurological examination, like I said, you have to see the symmetry of shoulders and iliac crest. So this is physically, these are subsets which have to be seen while seeing a patient of scoliosis. So what do you do first step is, first as the child comes in, you see the skin and neuromuscular system and evaluate the back shape. Then you do height measurement to check how the skeleton growth is happening. Has the child shot up suddenly, or the child has a stunted growth? And then number 3 is patient all long figures. You have to have a patient think about Marfan syndrome, and maybe having a patient having some connective tissue disorders and stuff like that. Maybe also having cardiac myopathy. Then you have a Ehlers-Danlos syndrome. These also need to be seen. When you are seeing a child with scoliosis, you have to keep everything open. You have to keep congenital open, option open, idiopathic. You have to keep Marfan's, Ehlers-Danlos, and many other diagnoses in your mind. You may have a child who walks with a high curved or a cavus feet, and this may be associated with Charcot-Marie-Tooth disease or any spinal disease. You may see a capillary spots on the back, or you may see axillary freckles, may be suggestive of neurofibromatosis. You may see a dumpling, or you may see a hairy patch at the back, which a patient may be having a myelomeningocele. You also may see a patient who's not able to pass urine or has difficulty controlling a bladder. So these are all things which you see a child at different age group, and these have to be noted. Is very important. Tag staging is a separate topic, but this is something which needs to be seen, and you have to correlate to see how the age is and how the patient's puberty is and how the patient's going to get worse with time. So you see a child like this, a patient comes to you, you want to see the symmetry, you want down the age, you want to note down the height, you want to note down which side the curve is more, you want to note down which shoulder is higher, which hip is higher, are the iliac crest level or not, is it the shoulder balanced or not. So these are all things which you keep writing down before even touching the patient. So then you come to the physical exam to touch the patient. So here you evaluate the balances, you see the reflexes and neurological deficits from top to bottom. You may have a CV junction issue, you may have a sensory issue, but these all have to be seen. You make the patient walk in your OPD and you observe how the patient is walking, the toe walk, healing, or anything. These all have to be noted down. Then you see the weakness. It may be patient may be having a tumor inside his spine, or maybe having some osteoblastoma or anything like that, which may be causing these issues. So you also see all that. You have to check for sensory, and also have to check for reflexes. So for child, especially young, below 18-year-old kid comes to you and complains of back pain or deformity or something happening in the spine, you have to treat it. That it could be congenital, could be neurological issue inside, could be a tumor, could be idiopathic, but you have to note down all these things. So the test of flexibility, which I'll do for the spine, is you can do the Adams forward bending test. I'll just talk about it. Then you have the pushing the curve from convex side and noting the correction. So you make the patient bend forward, touch the feet, and you try to press down on the rib cage and to see if it's moving or not. You can even make the patient bend down and make the patient turn left to right to see how much flexibility in the spine. Young, I mean, 15, 20 kilo child, you can even lift the patient from the head or under the shoulders and try to see if the spine is flexible or it's very structural or very hard. You have to do a lateral bending test. So this is to understand that patient has a structural deformity, is a hard deformity in the spine, maybe having a hemivertebrae or something which is not able to move, or you may be having a supple spine in which the patient pick up the patient from the shoulder or the head, that you will see that the gravity kind of actually comes little get balanced. So those are supple spines. Adder test is very, everyone should know this one test. You use the patient back. You measure and see how which side it's shifting at. Then you make the patient shift forward. You just tell her or him to bend forward and try to touch the feet, and then you can see that the bend happens on one side. So you can measure the bend and you can see the rotational asymmetry of the back. If the bend goes away, obviously scoliosis. If the bend accelerates, it's a segment of scoliosis. So once when the scoliosis is suspected, now that you know that the patient may have some scoliosis or maybe have some deformity or kyphoscoliosis or something happens, you have to correlate your findings. Can you hear me? Hello?
Yeah. There is network issue.
Audible, sir. Yeah.
Yeah, audible.
I know what.
Yes.
Okay, so
Yes, sir.
so when you order a good scoliogram, this is a 16 by 14 film, which actually will cover the whole spine from the C1 to at least down to the pelvis in both films. If you can get that film done, most important, because then you can see a view as well as lateral view, and you can measure how much kyphosis there is, or how the striatal profile is, and you can measure your end and stable vertebrae and do all the lines. So you try to order those. Never order a film like the one I've shown right now, because you'll not be able to check exactly what's happening. So you do a plain X-ray, you are standing 36-inch cassette, which is very, very important. You do posterior to anterior, and you decrease the thyroid and breast exposure by 3 to 7 fold by just doing this stuff. So you note the rotation, you measure deformity by Cobb's method, which I'm just going to talk about, and you check for skeletal maturity if the patient's, like you see the recess sign. So I'm just going to talk about these things. So a lot of times when you go up to your senior and tell them, so that this is a scoliosis I've seen, and this is the X-ray, and consultant might say, okay, where we're talk about. So you have a thoracic cycle. Most level. If you have a thoracic between T and have a thoracolumbar if it's between T12 and L1, and if you have a lumbar apex if it's between L2 and below. Then after that, patient has to be, you have to say if it's a primary curve or a secondary structural or a non-structural curve. So you have a 36-inch film like this. So what you do is you, first of all, you draw a CS will. So central sacral vertical line is drawn right in the middle of, you draw a line over the in the crest, and you draw a line right in the middle of S1, and you take it up all the way like this. So what you do is the end vertebrae. This is the E at the end vertebrae. They are the most tilted, and the apex is this vertebrae deviated furthest from the center of the vertebral column. So if you see this vertebrae, it's tilted, most tilted towards the curve. This is the one most tilted towards the cuff. So this one kind of gets a little balanced. Similarly, this one can get a little balanced. So these are the end vertebrae. These are most important when you want to find out what levels you're going to fuse, as well as when you're going to take out the Cobb's angle. Neutral one vertebrae is the one that is not rotated. So you see this vertebrae, you can see both the pedicles here, and here you can see that half a pedicle is missing, and here you can't see pedicle at all. So the neutral vertebrae is the vertebrae in which that vertebrae is not rotated. Then you have the stable vertebrae, where you draw the CSVL line, and if you draw a line up, the vertebrae which is most bisected by it is called the stable vertebrae. Things which you have to understand: you have the end vertebrae, neutral vertebrae, stable vertebrae, and the apex, as well as CSW. So what is CSW? The central sacral vertical line. So this is to, if you have just said it, it is very good to understand the coronal and the positive and negative coronal balance. So you draw a line all the way from down, all the way, and continue all the way up on that X-ray. Here you can identify the stable vertebrae, you can evaluate the coronal balance, and you can determine the curve type. And in respect to the classification system, you could use King or Lenke, but this is must to do for your planning. What are major curves? Major curves, like I can just say, is they are structural curves. Basically, they are the ones, the large normal curves in the scoliotic spine, and the first to develop. So you may have a thoracic curve, you have a lumbar curve, you may have a thoracolumbar curve. But the curve which happens first is called the primary curve, and then you have the minor, which is non-structural. This is the one which is to compensate for that. So if you have a right-sided curve, primary curve, you may have a left-sided a minor curve to compensate for that. So the two terms are major and minor, structural and non-structural. So this is a very important slide. This is to find out a Cobb's angle. This is oftenly asked in your questions. Like I said, you choose the end vertebrae proximally, and you choose the end vertebrae below. You take a line drawn from the superior end plate of the proximal end vertebrae, and the inferior end vertebrae, you take the inferior end plate and you draw a line from here to here. Where they meet, from there you draw another 90 degrees angle, and the angle which is formed is called the Cobb's angle. So quite a thing now you have software on the like you have on the x-rays itself which tell you how much the Cobb angle is. But if you're imagining it yourself, so you have to understand that if you see a patient today and you see in about a patient in 3 months or 6 months, if there is Cobb's angle increase of more than 5 degrees, that means there's something happening and it's a progressive curve. But you must understand this is an APU, so it's not taking into context how much the patient vertebrae are rotated, or if it's kyphoscoliotic deformity or not. So you have to understand this is an AP examination which calls the Cobb's angle. Other thing which it have a difference is you have a diurnal elevation of 5 degrees. You can if you do one in the morning or do it at night, you may have a 5-degree difference. You may have a vertebral rotation, so and the angle may change according to the rotation of the vertebrae. So you're not able to actually say it correctly. Even prone positioning anesthesia during sometimes is followed by a post-operative rebound effect with loss of correction when the patient returns to standing position. So you may have a difference in the Cobb's angle. You may have an error of 2 degrees to 7 degrees. So if I'm doing it or you are doing it or the radiologist is doing it, you may have a 2 to 7 degrees angle. So that's why when they say that patient is not 36 degrees and he comes to your clinic, you measure at 42 degrees, but you have to take like a mean. So defining that is very important. Last is intra-observer variation, like I said, that can be up to 10 degrees. So, just by your measure or everyone measure can to 10 degrees. So it's not actually good, but you do get an angle what is happening in the spine. How to measure vertebral rotation is also in X-rays. You do a NAMO method in which the pedicle location is seen on frontal AP radiographs. So what you do is you take the half vertebrae. This is the vertebrae, this is the pedicle body, and you're seeing an AP view. So you divide the half vertebrae on the convex side. Please remember, on the convex side, the one which is outer, and the convex side, and divide into 3 segments. And rotation is quantified in the base of pedicle location in regard to the segments. So you maybe have from A to E, you have different lines. So you have an A in which then you can see the pedicle here, which is neutral position and nothing's happening. Or you may have an E in which the whole, it's grade 4 where the whole vertebrae has shifted and the pedicle has come from the convex side to the center. So you're bang on seeing a pedicle. So this is to measure the calculation. The last thing which you want to see here is skeletal maturity. So very, very important. The risk index is like a short note, and it always comes, you do an AP view. In this you can you can just see that what the grades are. You can see a grade 1, grade 2, grade 3, grade 4, and grade 5. So basically what we understand is Risser index grade 0 is no ossification at all. You have a young child, maybe a 9-year or 10-year-old child, and there is no ossification happening. So you know that this child is going to grow a lot. It may grow for another 6-7 years. Or you may have a grade 5 in which you may have a 14-year-old girl come to you and they will ask you, sir, how much do you think will grow? How much will get worse? So you do an AP view of the pelvis in that X-ray and everything's ossified. It's grade 5. So you can confidently tell them that, it's not going to move too much after this. You're 14, you've already attained skeletal maturity. So don't worry. So this is very important. When you classify scoliosis, I'm not going to talk about it because you're just dealing with the physical examination part, but you have to understand maybe idiopathic, congenital, developmental, neuromuscular, tumor associated. So you have to keep this end of your back of your mind too when you're seeing a patient in your clinics. You can also do contact linkage. You have to spend about a good time to understand the system. But when you do, it's really good, and it's also very prognostic and also very helpful in doing your surgeries. So this is basically you talk about the thoracic and the thoracolumbar, and then you start seeing where the main part is. In the thoracic, then you have curve modifiers and stuff like that. But you can look into it beyond the purview of this talk. So what are the main indications for further imaging? So you have a guy who's come to you and you've done X-rays. So when will you do, if the patient has a lot of pain, if the patient has some fusion on the X-rays, there's a lot of vertebrae, there's congenital hemivertebral happening. A patient may be having a third cord or a C1 junction or they have CV. further imaging. From MRI TV junction, you can start seeing suppose something that you come down, talking, sorry, I know what's about. So basically, MRI CV junction with whole spine has to be ordered in this. So to see where or what's happening. So indications for MRI in patient. So if you have an age less than 10 years, signs in neurological deterioration, rapid progression, foot deformity, back pain, neck pain, and headache. These are all clinical features in which you want to do an extra MRI. So you have to see the curve type. If you have a left thoracic or a double thoracic or a triple major, you again want to do your MRIs. If you see a wide spinal canal, you see a thin pedicle, you think there's a tumor happening inside, again you do a MRI. So what's the risk for progression? These children which you've seen, you examined them, you got X-rays done, you've done MRIs, and you want to see how to go ahead to plan your surgeries. So you see the younger onset, the faster they come to you, they're going to progress more. If you have this as 0-1 as presentation, that means 60 to 70% progression will happen. If you have this as 3 and 4 and 5, it's only about 10% risk of progression. So menses start after the growth spurt. So that's very important to note down your menarche. Obviously, females are more likely than male. Curve pattern, if the apex is above T12, there's going to be a lot of progression. And degree in presentation. So if you have a 29 degrees, first time when you see the child, there's a 68% chance for progression. But if you have a patient who comes to you only at 59, 30 to 60 degrees presentation, you have a 90% risk of progression. So basic principle, what you do in these patients, it's another talk, but I'm just going to just touch about. You can observe the patient if the Cobb's angle is that less than 20%, and you do that till the patient comes to you every 4 or 12 months, and you measure your Cobb angles every time. Like I said, more than 5 degrees at every visit, then is a chance of progression. Bracing wise, there's another talk after me which is going to talk about bracing, so I'm not going to touch it. But yes, bracing is good in some cases, not in the congenital ones, but like yes, in the ones which are in the gray zone, that is when the 20 degrees to 45 degrees. So you see these patients, you get your X-rays done, you plan your good bracing, what Boston's or Milwaukee, what a brace you advise, and you get X-rays in those braces and outside those X-rays, and then you do a mean Cobb to understand how much is progressing or not. So non-operative treatment, basically you less than 25 degrees, you monitor them every 4 to 12 months. More than 25 degrees, you monitor them every 3 to 6 months. If you have a child who comes more than 30 degrees in your first time, and it's a skeletal immature brace, this is also going to be okay. If the curve changes by 10 degrees in the brace, that also is okay. If the curve is more 40 to 45 degrees, then the patient is looking towards surgery. So you just have a little idea. So if you have a child, basically anything beyond 35 to 40 degrees, and you've been bracing the child, then you have to understand the patient is young, you have to see your risk grading, your TANF staging, the age of the presentation, then you start planning the patient for surgery. I'm not again going to talk about surgery, but I'm just telling you primary goal of surgery is to prevent curve progression. And in idiopathic scoliosis is mostly a cosmetic surgery. So you understand the secondary goals of the surgery are curve progression, trunk balance restoration, sagittal contour preservation, while leaving as many mobile segments in the lumbosacral spine as possible. So surgery, basically, the larger preview is the younger the child, bigger the surgery, and you have to plan for a long time. So you do the minimal invasive surgery, don't involve all the segments, and try to leave some flexibility in the long run. If the patient has failed bracing and you've come to every 3 months and still the patient is outgrowing the brace, that more than 10 degrees Cobb angle progression is happening, again, the patient looking at surgery. If you have curves more than 45 degrees, yes, the patient looking at surgery. If you have unbalanced curves, one it looks very bad, one shoulder is high, the right shoulder is very high, and the mother feels that the rib hump is a lot. And yes, cosmetically, that patient needs to be operated. So you have a good counseling session with the patient, and you can take up the patient for surgery. And also, if surgery is fusion with instrumentation, so you have to hold it. So basically, when you see a child of scoliosis, you have to understand that they come at different age groups. They can come young as soon as maybe 2 months or 2 years, or they can come to you first time at when they're 8 years old, or even at 12 years old. But you have to understand, you note down your and have a system going there. Early intervention is the best results when treating scoliosis. You understand the shoulder height is what they will say, and a rib hump. These are things which the patients or the relatives will mostly talk about. That my one shoulder is high, or I have a big, my ribs are coming out, or I'm feeling my scapula is coming out. So these are things like this. And third is the patient is not able to balance the head itself. Then you have to understand scoliosis patients usually don't complain of pain. If they are complaining of pain, you have to get more go depth into the analysis, do your neurological examination, try to see when the patient pain happens, to get your MRIs and everything done, and then try to rule other causes of scoliosis. So bracing is common treatment. Like I said, up to 20-30 degrees, you can brace them and call them up for close follow-up, but they should be coming back to you, getting good x-rays, good monitoring scoliograms to understand if any progression is happening or not. If it's a surgeries, if our patient comes to you only at 40-45 degrees and is very highly rotated, and you feel that a patient may be having some congenital hemis or something happening in the spine, a lot of pain, patient has difficulty breathing or chest issues, you take up the patient for surgery as soon as possible. But it's not beneficial after skeletal maturity. So you have to understand the child's body is very malleable. It's like a cartilageous body. So you put your bracing, it's good. But the minute the patient develops skeletal maturity, the bracing has no role. It's going to cause more harm than good. So surgery is recommended for juvenile idiopathic scoliosis, like I said, in cases and patients of congenital scoliosis. Thank you so much.
Thank you so much, sir, for such a lucid illustration on such a topic which every postgraduate trainee is feared to deal with. Now, I have the privilege to invite our very passionate teacher, Professor and Head, Dr. Bhaskar Borgohain from Nigrims, Shillong. All over to you, sir.
Thank you, Dr. Vishal. Kindly let me know if I am sharing my screen.
Yeah, sir. You are on the way.
Okay, thank you.
Yes.
So, good evening, everyone. There was a very extensive discussion on so many topics. I'm back to the basic, that is acute spinal injury. And I'm sure a lot of you must have already seen case of spinal injury, which it's a borderline between neurosurgery and orthopedics, but many centers, they treat spinal injury. So the spinal injury basically involves the important and delicate soft tissue, the spinal cord, which is basically an injury which is low incidence but high cost of disability, and it requires tremendous change in the individual's lifestyle, particularly when there is a neurological deficit. And the incidence is around 10,000 new cases per year in a country like United States, in our country to be even more. If you see that it can involve at any level, the injury, but the injury is more common in the junctional segment, that is from the thoracic 11 to the lumbar 2, that is the junctional, the most mobile part of the spine, and also in the cervical spine, because these are the two areas where you have the maximum mobility, making them more prone to injury. So by definition, when the cord is injured, it is damage to the neural element and leads to functional deficit, which is either temporary or permanent. And these changes translate into loss of motor function, sensation, and autonomy function in the terms of neurogenic bladder and bowel, etc. Now you see the etiology. There are traumatic conditions like motor vehicle accident, fall from height, probably more common in India, and gunshot wounds, etc., due to violence. And there are non-traumatic causes of spinal injury, for example, infection and tuberculosis, pot spine, the various metastatic tumor, etc., which will have a different kind of outlook. Now, if you see the breakup here, you can see road traffic, then fall, then gunshot wounds, sports injury, and various secondary causes, non-traumatic condition. So when you manage cases, one of the important thing is to assess and identify whether this particular spinal injury is basically a cord injury or not, and if it is cord injury, whether it is a complete cord injury or an incomplete cord injury. I think it is the most important thing in the assessment in the initial stage and acute stage. Now, patient may be presenting depending on where the injury is. If the cervical spine is quadriplegia and paraplegia, we all know, or as quadriparesis or paraparesis. And our aim is to quickly identify whether it is incomplete and complete, because in incomplete, there will be sensory motor and functions are partially present below the level of injury, and some degree of recovery or even full recovery is expected. Whereas in complete injury, there is absence of all this sensation and motor, etc. And the prognosis usually is more dismal with very low chances of recovery. Now, the thing that will come in between is the spinal shock, because this is a period of areflexia after the spinal cord injury, and there will be loss of all neuronal activity below the level of injury. And this loss of activity includes loss of motor, sensory reflexes, and autonomic function, of course. And the cause possibly is, migration of the intracellular potassium ion from intracellular to extracellular space. And usually spinal shock will resolve most of the cases will resolve within 48 hours, but sometimes it might take days, months, or even very prolonged period of time. So the first thing you should try to differentiate is by examining for this bulbocavernosus reflex, which is the reflex which is going to tell you whether it is a complete injury or incomplete injury. And here, what you have to do is expose the patient well in the lower part in male, the glans penis in female, the clitoral area, and the anal sphincter at the same time. You have to have a proper light to look at it. You can squeeze the glans penis and look at the sphincter, whether it is squeezing, whether there is a wink there or not. If it is catheter, just pull the catheter. In female also, you can pull the catheter. And looking at the anal sphincter, if it contracts, means the bulbocavernous reflex is present. If it is present and the patient neurological symptoms remain the same, if it is 0/5, it is still 0/5, and this reflex is positive, that means the patient has had a complete spinal injury or complete spinal cord injury with a poor prognosis. If this reflex returns and patient has some neurological improvement in terms of sensory, motor, autonomic, etc., that means it is an incomplete cause. I think it is an extremely important sign. The next thing in the management is, while evaluating, is to classify the bony ligamentous injury. First is the neuronal, then we are coming to the stability component, the bony ligamentous, etc. For example, burst fracture, whether this is a kind of, what kind of classification it will fall into. For that, we must understand the anatomy of the spinal column and the relationship with cord very clearly. And we must understand the cross-sectional anatomy, where the various tracts, the anterior motor tracts, the posterior is sensory, in the lateral you have the spinothalamic tract. If we have these ideas better and understand the pathophysiology better, for example, spinothalamic tract is lateral, there will be loss of pain and temperature sensation, etc. And posterior column will basically carry the various kind of sensory components, the sensation, whether it is portopathic or epicardic sensation. Now coming to stability part, you have the anterior longitudinal ligament, which is anterior to the body, then posterior longitudinal ligament, the intraspinous and supraspinous ligament, and you have the dynamic stabilizer. These are the static, the muscles itself. Now coming to the blood supply of the spinal cord, you have various anterior and posterior spinal arteries and segmental arteries which reinforce the blood supply distally. As you can see here, arterio adamcuis is one, which sometimes is injured and can lead to paraplegia. And these segmental arteries has to be ligated even during spine surgery when you go for anterior approach, etc. And you have to be careful of cause of serious bleeding. Now, as you have seen, the bony ligamentous stability comes from annulus fibrosus, the ligaments that I have shown, and the facet joints, all this combined. And in the cervical spine, the stability is less, chances of dislocation is more. The facetal anatomy, because of increased mobility, the facet anatomy is different. Now, Dennis's three-column concept is very important to understand what is stable injury, what is unstable injury, because it divides the spinal column, the anterior longitudinal ligament, the posterior longitudinal ligament, and supraspinal ligament forms kind of a boundary to divide. You can look at the middle column, which is basically the posterior part of the vertebral body lying anterior to the pedicle, through which the spinal cord is very, very close. So when you say unstable spine, it actually means disruption of the middle column, where the spinal cord is very close to it. There is neurological deficit. Even if it is disturbed, it will be a unstable injury. There can be a real and potentially unstable under physiological loading conditions. So Dennis has classified the injuries into minor and major. Coming to major, the compression fracture, burst fracture, seatbelt type injury, which is a distraction injury, and fracture dislocation. In the minor, various processes like transverse process fracture, spinous process fracture. Here, this is a CT-based classification, three-dimensional classification. You can see the various types. The burst fracture is one interesting area. It is important to interpret the MRI. The basic skill should be there to understand the MRI. Here you can see almost a fracture dislocation of the cervical spine showing disruption of all the three columns. You can see that all the three columns are disrupted. This is definitely unstable fracture. Now, the examining the X-ray is important. So normally the deficit level, say if there is a deficit at T12, if the neurosensory deficit is at T12, it starts, T11 is okay. That means your fracture will be at least 2 levels higher. So the X-ray has to be focused at a higher level so that you don't miss that fracture. Similarly, in the cervical spine, the shoulder might be coming in the lateral view. You might miss a fracture which is lying in the C7 or or D1 junction. There you need to pull the shoulder when you took a lateral view. In the burst fracture, you can look for the interpedicular distance. If the interpedicular distance is increased, means it is actually a burst fracture in the AP view. Otherwise, it may be difficult for you to understand between the burst fracture and compression fracture in AP view in X-ray. There are other mechanistic classification. We will tell you the mechanism of injury like McAfee, Ferguson, and Allen, which you should also know. And coming to stable burst fracture, here you see anterior column and middle column is involved. The posterior column is intact. All the posterior structure, the stabilizers, the supraspinous, interspinous ligament, the facet, etc., intact. The pedicle is intact. Minimum kyphosis is there because of that, and no neurological impairment, no laminar fracture. That's why this is a stable burst fracture. Now, coming to White and Punjabi criteria, if there is neurological deficit, if the loss of height of vertebrae is more than 50%, if the angle is more than 20-degree loss of, say, kyphosis, increased kyphosis, there is dislocation, burst fracture with canal compromise of more than 30-degree, multiple adjacent compression fractures, and failure of 2 out of 3 column or even 3 column. These all constitute an unstable injury where you need to do. Besides doing a stability analysis, you have to do what kind of syndromic presentation, the neurogenic presentation, the spinal cord is having, whether it is an incomplete cord injury or complete cord injury in the form of central cord, anterior cord, posterior cord syndrome. If you can make a difference, it will be much better to prognosticate. You can also think, for example, here, if you see the anterior cord here, it is basically a flexion type of injury. There is a complete loss of motor power, but there is preservation of proprioception and vibration to some extent, and prognosis is poor. But whereas in central cord syndrome, you will have more weakness. This is when cervical spine is injured. There will be more upper limb weakness than lower limb, and prognosis is better than the anterior cord syndrome, and this mechanism of injury is hyperextension. So this will give a good idea about how to manage these cases. Here, the difference between conus and coda equina syndrome, one will present as upper motor, the conus, and coda will present as lower motor. There is symmetric as well as versus asymmetrical presentation, and level is higher in conus, of course, it will be lower in. So these are the basic differences you have to quickly make. Now, patient will always present in motor, sensory, bladder, bowel, either hyporeflex or basically they will present with an either upper motor or lower motor or a mixed pattern in certain cases, depending on the level. So the emergency action in the management is urgent medical attention is critical because treatment of spinal cord injury should begin at the site of accident, because immobilization of the spine is very important to prevent secondary injury and further destruction. If it is cervical spine, you have to quickly stabilize with a cervical collar. And if it is other area, you should transport the patient in a rigid board or a spine board. Now, you have to follow, if it is cervical spine injury, if the phrenic nerve may be involved, so there may be respiratory difficulty, and because of edema progressing there, you have to take care of that. ATLS protocol has to be used because of the rule out other injury, very important to rule out other injury like head injury, the visceral injury, thoracic, hemothorax, pneumothorax, etc. Immobilize and prevent shock and treat shock very well, because it can lead to spinal cord hypoperfusion, which can lead to irreversible injury to the spinal cord, even if it is incomplete injury. So it is very important to maintain a good blood pressure to maintain the spinal cord perfusion. It is ideal to transfer them to a comprehensive spinal unit or a trauma center with regional spinal injury center, where a comprehensive team will manage them. Avoiding possible complications. One of the important things I would tell you is to catheterize the bladder as soon as the patient comes, in case that there is the retention of urine, because that will prevent an uncontrolled expansion of the detrusor muscle, leading to further damage to the nerve supply to the detrusor. Even if it is incomplete injury, bladder may not recover. So this is very important. Respiratory area has to be seen. Tracheostomy may be needed because death is reported in cervical spine injury, so you have to take care of that. Deep vein thrombosis, of course, is a common denominator. We have to control this. Now, coming to the stable type of fractures, how do you treat them? So the treatment is non-operative oftentimes, and it can start with a bed rest, but we have problem with bed rest, so bed rest should be shortened. The fracture can be immobilized, at least stabilized, additionally externally stabilized by some sort of braces. But sometimes there may be potentially unstable fracture, which might require kind of a prophylactic surgical fixation. So, and patient has to be managed with a log roll maneuver and special bed and mattress to prevent bed sore when we are treating it non-operatively. Earlier, methylprednisolone was used in the National Acute Spinal Cord study in US. Within 8 hours of injury, they said mild improvement, but side effects were extremely more important than the improvement they have seen, and it is no more actually popular among these things. So now coming to surgery, where do you go? When do you go for surgery? What is the primary goal of surgery? The surgery is basically done for unstable type of injuries where there is neurological deficit, when there is column disruption, and when there is a potential instability that there is a danger of the patient going into neurological deficit, like an unstable, potentially unstable burst fracture. Now, the goal is to provide the column stability to the spine and decompress the compressed neural element, and so as to create a conducive environment for the neural tissues to recover and potentially recover. Secondary goals, of course, particularly in complete injury, when there is a complete, say, a fracture dislocation where you suspect a complete injury, there will be pain relief when we stabilize the fracture, early mobilization of the patient out of bed and reduce the length of stay or hospital stay, and prevent certain complications of recumbency like bed sore, UTI, pulmonary, complication like the DVT, pulmonary embolism, and hypostatic pneumonia, and reduce the huge burden nursing care can come when person is paraplegic. So these can be in the complete group as well as in incomplete group. Now, surgery is needed to remove the compressing element like foreign body, like a gunshot injury, the bullet if it is lying inside, the bony fragment, the retropulse fragment from the anterior, which is pushing from anterior side to the spinal cord, herniated disc, etc. And this may be needed also to stabilize the spine overall to reduce the pain and deformity, as I said. Now, coming to the approaches, when I was doing my post-graduation, anterior approach was very, very popular. But then later on, we found a lot of complication happening with anterior decompression because the approach is either transthoracic or intraperitoneal, transperitoneal. So more and more familiar, the approach and easier approach has been advocated later. Posterior approach has become popular than posterolateral decompression. So advantage of posterior approach is that many a time there is injury to the the dural tear is there. There is a fracture in the lamina. So these things, if you can approach from posterior side, you can address this pathology. You can examine the cord. You can repair the dura. So these are certain advantages of posterior approaches. Whereas in the posterior approach, you might actually decrease the stability by removing the facet joint, which provide posterior stability. So you have to be judgmental in that. Posterior compression system and distraction system, two type of system may be used. Now coming back to your classification, of mechanistic classification, if it is a distraction injury, like a seatbelt injury, whether it is through the annulus fibrosus or through the bony vertebra, you have to do a compression plating or compression system, put rod and screw and compress the fracture or the elements. Whereas in compression fracture, when there is a compression fracture or burst fracture, probably you will be repairing distraction so that you can gain the length in the vertebra and you can get ligamentotexis either through the attachment of the fragment to the posterior longitudinal ligament or the anterior longitudinal ligament. Now, anterior decompression, where it is advocated when there is a the bony fragment is to posterior superior vertebral body. There are also studies they are saying that when you do anterior decompression, the chances of recovery from the motor part as well as from neurogenic bladder is superior than when you do only posterior decompression, particularly when the patient comes late to the hospital and presentation is late. Example of surgery where you can do a corpectomy, complete removal of the vertebral body and fusion and do a locking plate in cervical spine. You can see here in this case surgeon has done anterior decompression, gain the length, and done is anterior fusion, spinal fusion. Similarly, indirect decompression is possible by using the various the methods through the posterior approach, putting the pedicular screw, using the maneuver to gain length. Here the ligamentotexis to the anterior longitudinal ligament here, and of course posterior longitudinal ligament, but the anterior longitudinal ligament is using as the main texas force. You can use a metallic case in corpectomy. Here you can see these cases, posterior decompression, and then even the screw can be put into the fracture vertebra halfway, and if required, anterior case will be put, as you can see in the cervical spine. Anterior case is put after doing a corpectomy decompression to create the conducive environment, decompress all the elements. Here you can CT scan beautifully shows retroflals bony fragment encroaching into the spinal canal, more than probably 60% of that. And here also in MRI, you can see this is a T2 view, T2 image showing the CSF as white, and also see some element of posterior element disruption here, the intraspinous ligament probably edematous as well. Now here you can see there is a 360-degree fusion done here in this case. You can see the case being put anteriorly, entire area is decompressed. Similarly, here is another example of surgeon doing anterior decompression and doing locking plate and rod screw system to basically stabilize the spine after decompression and early mobilization for pain relief as well as a proper rehabilitation. So in short, these are the same approaches that you can be used to manage the. So in summary, I would say in the acute spinal cord injury, it is very important to save the patient. In cervical spine, you have to be even more careful, take care of the airways, control the blood pressure so that the spinal cord does not undergo hypoperfusion. Exclude other injuries and take care of all other associated injuries can be life-threatening, and immobilize the spine carefully. Classify very quickly into stable fracture or unstable fracture. Classify early by repeated examination by bulbocavernous reflexivity, complete or incomplete injury. Classify according to various syndromes to justify your prognosis so that you can communicate, plan your surgery. Think about the mechanism of injury and the classification. Decide what kind of surgical intervention or non-operative intervention will be required. So in the rehabilitation, basically, we prevent complication like all the complications that can happen in a neurogenic bladder, the urinary tract infection, the sympathetic hyperreflexia, which can be again a life-threatening condition in cervical spine, which can lead to cerebrovascular accident with accelerated hypertension, and depression, psychogenic causes, and all other causes we know: pressure sore, deep vein thrombosis, pulmonary embolism, contractures, and respiratory complications, etc. We know about the wheelchair mobilization, all the avoidance of pressure sore in rehabilitation part, and the entire team of rehabilitation team. Everybody has a role to play, including dietitian, the psychiatrist, and social worker. And technology has come a big way to help people where the treatment is palliative, when you are dealing with a complete cord injury, where despite surgery or despite stabilization or despite best of your effort, patient may not recover. And newer things like robotic gait trainer, etc., and computer adaptive technologies are available to help this paraplegic or quadriplegic. So with this, I sum up and thank you everyone for giving me this opportunity and for your patient hearing. Over to Vishal.
Thank you so much, Professor Vaskar, for such a practical-based approach in your talk. So, next. Am I audible and visible?
I think you are audible, yes, but not visible yet. You're audible.
Mr. Shobit?
Yes.
Visible now?
It's visible,
and
but
visible?
I'm seeing only the Zoom screen. Launch meeting. Maybe you have shared.
Is my screen?
Can you just share screen again? Dr. Vishal?
Yeah. Just. Is it now visible?
No, I can't see. Means
but
like
I am able.
It's coming like the Zoom screen is coming. Your just close it to whatever is there. Yeah, now we can see. Right.
Say now.
Yes, we
Is
can
it?
see now.
Okay,
You
fine.
can see now the full PPT.
Yeah. So good evening, everyone. Yeah. So the last talk of the day is application and indication of spinal braces. See, this is a very vital for any exit exams, be it by MS, DNB or FRCS. And this is any postgraduate trainee or anyone, any orthopedic surgeon or spine surgeon will see come into will encounter this or will come into touch with all these things into their routine day-to-day practice. So we need to know almost each and everything about a particular brace. These are just a few salient points because they are just to instigate the viewers, just to instigate the delegates that they have to learn these things. I will request each and every one of you to feel motivated after this. Just go home, access your internet or maybe open your book and then read all about these individual braces. So in my next few slides, I will be touching on to 3-4 commonly used braces and orthoses. So to start with, we all need to know what the definition of an orthosis is, what the definition of a prosthesis is, what is disarticulation, what is amputation, because these are very basic questions. Without answering this, no one is going to make you pass in any exam. So we need to identify the orthosis shown in the picture. We need to describe its function. What are the indications, its indications? Why is there a hole in the center of the anterior part? And need to know a few more similar orthoses. So it's a Philadelphia collar. So you need to know what a semi-rigid or a rigid orthosis is. Its function is as a kinesthetic reminder. It controls motion, flexion, extension by about 65 to 70% and rotation to a lesser extent of about 60%. Useful in acute traumatic cervical spine injury for brief splintage, for cervical myelopathy, mild cervical instability, or for post-halo removal. This hole allows for placement of tracheostomy tube or emergency cricothyroidotomy without removing the orthosis. Other similar ones are soft cervical collar or rigid collar. So this orthosis, we need to name the various parts of it, describe its function, and what are the indications for it. This was just meant for an interactive session, but as the time is running by, so I'm just putting on the next slides. So this is a sternal occipital mandibular immobilizer. Its different parts are anterior sternal plate, which fixes on the sternum, which sits on the sternum, mandibular support sitting beneath the mandible, occipital support, 3 connecting rods, 1 anterior and 2 anterolateral. It has a shoulder harness and trunk straps. Immobilization of cervical spine is its function. Best results obtained up to C5 level. Extends into the thorax for better control of motion. It's a stable, indications are, it's for stable cervical spine fracture dislocations, moderate to severe soft tissue damage, and for atlantoaxial instability. The next one is, we need to identify this orthos. These are the very common questions which a Viva examiner will begin with. And then as you answer well, you proceed on to next questions. Describe its parts, how it functions, what is it used for, and list some of the complications. So this is a cervical halo vest. It's a rigid invasive bracing system where screws are directly inserted into the skull. Its parts are its oval metallic or carbon fiber ring with 4 pins, padded thermoplastic vest, 4 metallic bars, and the waist. It provides maximum motion control at all cervical levels. It's unstable fracture dislocation of cervical spine, upper cervical spine injury, and odontoid fractures are its uses indications. The complications are loosening, pin site infection, dural puncture, nerve palsy, particularly the abducens, supratrochlear, and supraorbital. So the next is, we need to, the same pattern of questions follows. The first question will be identify the orthosis. If anyone fails to identify this orthosis, he is bound to fail this in the exam. Describe its parts, how it functions, what are its uses. So this is a thoracolumbo-sacral orthosis, commonly called as Taylor's brace. It has an abdominal corset with thoracic extension, paraspinal bars, shoulder harness and straps. It is used for immobilization of the spine in pathologies involving D4 to L2 vertebra like osteoporosis, stable vertebral fractures, degenerative disc disease, pot spine, and in post-surgical immobilization. It works on the 3-point pressure principle by which flexion extension movements are restricted. Also, it increases intra-abdominal pressure, adding to spinal immobilization.
Vishal,
Yeah.
In my slide, screen, the slides are not moving. I don't know whether it is moving in other participants.
Maybe Dr. Sobit can help you, sir, or Dr. Shabik can help you.
Okay.
So the next will be in identify the orthosis. This one in this picture, describe its parts, how it functions, what I see. These are the 4 pertinent questions. So this is an anterior spinal hyperextension orthosis, commonly called a Givet brace. It has anterolateral rectangular frame with pads. The pads are at the position of sternum, suprapubic, thoracolumbar, and 2 anterolateral, and straps. Used for immobilization of the spine, limiting flexion in pathologies involving D4 to L2 vertebra, prolapsed intervertebral disc disease, stable fractures, pre and post-surgical immobilization. It also works on 3-point pressure principle by which flexion is restricted and the spine is held in hyperextension. This one again with the same set of questions. So this is a lumbosacral orthosis, commonly called chair-back orthosis. It increases intra-abdominal pressure and contributes to segmental spinal rigidity or stability. Indications are degenerative lumbar spine disease, spinal trauma, osteoporosis, spondylolysis, and prolapsed intervertebral disc disease. The other similar ones are lumbosacral corset, thoracolumbo-sacral orthosis. The last one. So it's a special cervical lumbosacral orthosis called Milwaukee brace. It works on the principle of 3-point or 4-point fixation. Indications are treatment of scoliosis with a curve apex above D8 and a curve between 20 to 50 degrees. Contraindications can be congenital scoliosis with a curve less than 20 or a curve more than 20 or any curve in skeletally mature patients. Other similar ones are Boston brace. So these are the few braces which I have put up just to instigate your thought process. Go home, read more about it, and we would like to answer your questions. If not in this session, again, we will be coming back with a spine session maybe a few months later, because this is an ongoing program held every month on a specific date. So I think it's high time to conclude the session. Thanks delegates for 500 plus delegates being so passionate, and 12 plus more faculties almost all across India to be here glued to the screen, exchange of knowledge taking place on a day where festival is all around the country. Thank you, Team Integris. Thank you, Team Core Series, for such a wonderful evening.
Okay. Thank you.
Thank you, everyone. Thank you.
Thank you, everyone. Yeah.
So we put an end to it. We can leave the session, Dr. Souvik.
Yeah. Thank you, sir. Thank you, everyone.
Thank you. Thank you. Thank you so much. Thank you.
Recording stopped.